And it's kind of important. The thing is, even if you have no clue whatsoever what's going on with your patient, okay? And Dawson's like, yeah, I know. If you know what the body's going to do, how the body reacts in certain situations, then you know kind of what's coming up. You know what's about to happen, so you can kind of adequately prepare for it. Okay, so, and we were talking about shock a little bit, and Drake mentioned, well, treatment for shock, what was it? Lay them down, put them on oxygen, cover them up, right? That's what you do. That's what you're taught in ENT. In advanced, there's different treatments for different types of shock. All right, so we're going to talk more in detail about the different types and being able to differentiate between them and the specific treatments associated with those different types of shock. Okay? All right, so homeostasis, we said yesterday, balance, right? This is a complete balance within the body, and this is not a static thing, and this is always changing. There's always little things going on within the body to maintain that balance, because if we don't, we get all jacked up, tend to die pretty quickly. Good morning. When disease, environmental conditions, all that fun stuff, the body is going to try to fix it. All right? Somebody give me an example of what you think, how the body would try to fix a problem. A fever. All right, what kind of problem would that be fixing? Infection. All right, give me another one.
The body releasing stored glycogen and
all right, so if we don't have enough sugar available, we go to the stores, release those. Absolutely. All right, those are two very different examples, but they're both 100% correct, and there's a ton more that we'll hit on and get to. All right. Once again, we don't have to think about this. Our body just does it because it's awesome. Physiology. What's that? Function of the body. The pathology is when things go wrong, essentially, in the body. All right, and so the pathophysiology is how things go wrong in the body, how the disease processes work within the body. All right, and everything that happens to the body happens globally, all the way down to the cellular level. Okay, so it affects cellular level, tissue level, organ level, and then whole body level. All right, it just depends on what type of injury or insult that it is. Okay, the whole predictable ways to response. That's what I was telling you about. If you understand this stuff, it doesn't matter if you can figure out what's wrong with them or not, because they're presenting with these symptoms, so it's in this ballpark. We know what's going to happen next, and we can be ready to treat it or address it. Okay, it's like a little cheat book to the body, taking care of your patient. All right, so problems that you think would require an immediate attention or action. What are some of those? Shock, bleeding. What else? Code, yeah, that one tends to get there. What else? Respiratory issue, problems, emergency. What'd you say? Open femurs. Why would that be a problem?
blood loss.
Blood loss. Plus it's painful. Why is it painful?
Because your bones poking out of your thigh.
It is, but usually what causes the actual pain, because you have very minimal pain receptors on the bone itself. But what happens is normally it's lined up, right? And you've got these giant muscles, your quads, attached to it. And they're kept in perfect tension when they're attached properly. But when the bone ends are disrupted, one's poking up through the skin, now it's shorter. That muscle is not being held at the proper tension anymore, and it goes, and it turns into a giant muscle knot. So if you've ever had like a muscle spasm, picture that in the biggest muscle group of your body. All right, and that's what's happening. Your muscle gets all knotted up. If you ever get the opportunity to see one, like if you're palpating the leg, you can actually feel that muscle knot in that leg a lot of times. And that's what's causing that extraordinary amount of pain, which is why it hurts when you put tension on it. They holler. But if you can get on in a proper traction and traction splint it won't kill the pain completely. But it will help with some of that pain. It'll take the edge off of it at least. All right. Potential underlying causes of problems usually is going to boil down to, and most everything that y'all mentioned boils down to one of two things. Involving cardiovascular to include bleeding, a pump, a container, or content issue, or a respiratory issue. All of the things that y'all mentioned boil down to those, all right? everything in life boils down to those. If we've got a problem with there, it will affect the rest of the body, whether it is obvious at first or not, okay? So underlying causes, why is that important? To understand what's going on. In other words, EMT, somebody's having breathing problems. What do you do? Breathing problems. What do you do?
Give 'em oxygen.
Give them oxygen. All right, how much? Depends on how bad it is, right? So if they look like they're having a bad day, you give them more. If they don't, you give them a little less. All right, so here we're going to differentiate what's causing that breathing problem. Is it asthma and they've got a bronchospasm happening? Or is it pulmonary edema and they've got fluid buildup so that they've got a VQ mismatch? Or is it broken bones so they're hypoventilating? Because the treatment for all three of those is very different. All right, so now we're looking more into the why things are, what's causing it, so you can specifically treat the underlying cause, not just the reaction. Does that make sense? All right. EMT, putting oxygen on them, very important, but you're not doing anything for the underlying cause. Now we're going to start looking at that underlying cause for most of these. Okay. There's some things you still can't do anything about. It is what it is. But the things that you can do something about are very important. All right? So, Colin and Tyler, they are AEMTs with Bayside EMS. They've arrived on scene. They get a report for a person down, unknown any further, at an outdoor cafe on the boardwalk. Okay? As they approach, they observe the patient is a woman in her 30s who looks abnormally pale and seems to be unresponsive. What are y'all's thoughts?
Shock.
Blood sugar.
Blood sugar, shock, anything different?
Drunk.
Get drunk? What else? Anything?
Hotel.
Drugs, overdose of some sort? All right, so we've got OD, we've got shock, we've got blood sugar. What else did we say? Is that it?
Drunk.
Well, I'm going to include that with the OD, alcohol, drugs, something of that nature. Then, all right, those are all differentials. You ever heard of differential diagnosis? That's what you're doing every time you go on a call. Most of the time, it's like a game to me. Be with my partner, be riding to be like unknown, unresponsive. All right, I'm going with blood sugar today. Or depending on what part of town it is, all right, I'm going with OD today. You know, if it's at the PD, it could be faking it, could be drugs, could be hidden drugs that have ruptured. So, you know, you kind of thinking as you go, because why do we do that? What's the whole point behind that? Behind besides just being kind of fun sometimes, but win a bet with your partner, buy lunch, or so you can know how to treat them, or both. All right, because how we treat an OD versus shock versus blood glucose versus dead is going to drastically vary, right? So you kind of need to get an idea of what approach we're going to take. Can you rapidly rule out blood sugar levels?
Yeah.
Absolutely. So that one you can hit pretty quickly. Can you rule out dead pretty quickly?
Definitely.
Absolutely. Shock and OD. What about those?
OD you can rule out quickly.
Depends on what it is.
Shot, probably.
Depends on what it is. So we're going to have to go beyond just our initial vital signs and rapid assessment. We're going to have to dig a little deeper to go any further than here, right? All right. But either way, you've still got kind of a game plan in your head because you know, all right, we're going to check this, and this. Here's how we're going to approach it. All right. Middle-aged male tells Colin that he noticed the woman slumped over a table and called 911. He didn't see any obvious reason for her condition. A young man who works at the cafe adds that the woman bought a sandwich and sat down to eat about 15 minutes ago.
I'm thinking blood glucose.
All right, so we're still thinking blood glucose. You said food poisoning. Any other ideas? All right, so choke. Anything else?
I wouldn't really think that it would be blood sugar because if she ate, then she.
So she sat down to eat. How would we know if she actually ate any of it? Look at the food, right? Is there food still there? And if there is, does it look like it's been munched on? You know, little things that you just kind of take for granted, but those are little things that can give you clues as to what's going on. All right? Food poisoning could be, but that's like some CIA level stuff because in all reality, food poisoning usually is going to take a little while to kind of start kicking in, but it's not out of the realm of possibility. All right? When they reach the patient, Colin and Tyler hear a harsh, high-pitched sound each time the patient struggles to take a breath. All right. At the same time, they note the patient's lips, ears, and nail beds are a dusky blue. Okay. Everybody look at Sammy's shirt. That's dusky blue kind of on people. All right. It's not a bright, pretty blue. It's kind of a cornflower blue, if you will, almost to me is what kind of reminds me of just a paler blue, but kind of a little darker gray mixed in. All right. Let's see where we're. Colin positions himself to lift the patient to the ground and feels that her skin is cool to touch and diaphoretic. Okay, so it still could be low blood sugar.
I'm guessing, I'm going with choke now because
Choke?
of the airway sound.
Is the airway sound? What is that airway sound? Stridor. All right, is that an upper airway problem or a lower airway problem?
Lower.
It is upper. Stridor is upper. What can cause stridor? What is the cause of stridor overall? Some sort of airway obstruction, whether it be swelling or food or something else. Something is closing off the upper airway. All right? So that's an important thing to note here, right? What does that mean for her? Beyond the whole, like, what's actually wrong with her, but in the immediate here and now, what do we know is wrong with her? Airway problem, right? So that's got to be addressed. However we do it. Then we know, light bulb, something's wrong there. All right? So, problems that require immediate attention. That airway, what are we going to do for that airway? Head tilt, chin lift. Do we have any indications of trauma that would not be appropriate?
Nope.
Nope, I say roll with it. All right, so head tilt, chin lift. If that doesn't clear, if that stridor doesn't get better, what do we do?
If you can see it, suction it.
All right, so we're going to look maybe to see if we see anything since she was eating. Okay. What if you don't see anything?
Like a finger sweep?
Don't do a blind finger sweep, okay? If you could see it, you could try to do a finger sweep. Y'all use a bite block. Right, those little pieces of plastic, about that long, about that wide. Put it in there in between the teeth. Okay, because if not, somebody's going to chomp down on your finger. It's going to hurt really bad. All right, they might take skin, muscle, bone. Don't do it. All right. But, so if we look in there and we see something in there, then we could remove it. What if we don't see anything? We're going to get ready for transport. Is there anything we need to do immediately before transport? O2. What all can we do on scene? What all should we do on scene when we've got a significant problem going on?
We need to do a quick head to toe assessment.
Call help now, I think. Help. When on scene, the only things when you, let me back up. Is she critical or non-critical?
Critical.
Critical, yeah.
She's critical because we have that airway compromise, all right? We don't quite know why yet, but it's there. So if you have a critical patient, the only things you should be doing on scene are your intermediate, your life threats, okay? Your immediate life threats. So anything dealing with airway, bleeding, breathing, circulation. And to do that, you got to do a quick head to toe. Y'all, I'm talking, when I say quick head to toe, done. About 30 seconds. All right? Should not take very long. You're looking for more life threat problems. Flailed chest, any bruising, bleeding, anything obviously may give you a quick clue, bless you, as to what's wrong with that patient. All right? So oxygen. What kind of oxygen do you want to give her, Ethan? High flow. So via non-rebreather? Does anybody want bagger instead? Or y'all want to do non-breather? What's bag going to do? It could. Could dislodge it, could push it in further. Do we know for sure if there's anything actually in there?
No.
All right. So,
It would depend on how many breaths she's taking.
how many times does she breathe is a good question. Is she completely unconscious or is she just lethargic? I want to look at her body and see what her body looks like. Because to me, the top two contenders are foreign body airway and anaphylactic reaction. Because stridor could also be caused by swelling of that airway from an allergic reaction. So, to me, those are my top two contenders. It's very difficult because we don't have a picture of what her skin looks like. Yes, ma'am?
Would it, like, if her airway was swelling, would her face be swelling?
Maybe.
Mine didn't. I just got red and rash.
This swelling right here outside is called angioedema, and you may see it, or you may not. They can have some lower airway or like mid where you can't see, like inside swelling, where that airway is just closing down and you don't see anything outside as far as that goes. Most of the time, though, if you have that to that degree of anaphylaxis, you're also going to see some kind of skin signs. All right? You'll see hives, spots, something, wheals, something usually, redness, that will kind of give you that clue. So, to me, those would be the top two contenders there, just because of her presentation of the airway. So, for her, I would want to know what her oxygenation is. Okay, if she's got poor oxygenation, what's our treatment for foreign body airway if they're unconscious? CPR, all right, which has a chance of dislodging if something's in there. In all honesty, I'm going to look for a bracelet, seeing if there's any kind of allergy alert. I'm going to probably grab her purse if I can, get somebody to look in there, see if she's got an EpiPen or something like that. Other clues that may give me an idea. I'm going to look at her pulse. If her pulse rate is fast, could be shock, could be compensation, all right? I'm going to probably bag her just because of that stridor, because I know she's not moving a lot of air. You know, I would strongly consider IM and Epi, just in case. If I didn't have anything that definitively ruled out anaphylaxis, and I thought it was a possibility, for me, is that IM Epi going to hurt her?
May.
Is it gonna hurt? No.
Probably not. I mean, there's always a slight chance anytime you give it a drug, but most of the time, that IM Epi is not going to harm them. Not in her case, not in the foreign body airway or something like that. All right, but if it is anaphylaxis, that's the one thing that's going to help it. How else might you differentiate as far as vital signs? If you had foreign body, what would you expect that blood pressure to be? Probably normal-ish, maybe high, but you know, it wouldn't be low per se. All right, whereas anaphylaxis, typically your blood pressure is going to be a little bit lower, so that's another thing that you could kind of look at and help guide your treatment. But do y'all see why it's important to understand why we got to this point? Because what we do is a big difference from treating one from the other. But we all know, no matter what, got to hit that airway, right? So we're going to manage that airway while we think and go, what the crap is going on here? Figure it out. Yes, sir.
The last time that I had an anaphylactic reaction, my blood pressure got really, really high for about 20 minutes. And
Did
then
it?
started going
That's
down.
very unusual. Were you full-blown anaphylaxis, like respiratory compromise
Well, see, I was
too?
already, yes, I had,
Had you taken your Epi?
I hadn't because
Okay.
here's what had happened. I was already
Epi
at the
can cause
hospital.
both.
I was already at the hospital when
Mhm.
it happened, taking my basic class,
Mm-hmm.
and it got my airway was really the worst thing that happened before I got Epi, because I just went down to the ER and that's what they gave me Epi and stuff.
Mhm.
But the doctor said that in some situations, because mine was more of a residual
It
reaction,
just kept
'cause
on
I'd had one-
happening.
I'd had one a day before.
Yeah.
And he said sometimes in residual reactions, your blood pressure will shoot up really, really high and then start going down.
Because your body's still trying to compensate and get rid of the problem. That also happens with asthma attacks. You can have the initial attack or problem. That's why we always suggest to transport if they're having any kind of allergic reaction or asthma attack, because it can come back later, usually within about 24 hours, and be worse the second time around. All right? It does happen. Weird things. What's it called? Do anybody know just off the top of your head by chance? We'll talk about it if not. But what it's called when you have an abnormal reaction, like say 90% of the population reacts this way to this, like i.e. Benadryl. What does Benadryl do to most people? Makes them sleepy, right? But there's a small percentage of the population that jacks them up. They're like prairie rats on crack. Like they're all jacked up and ding, ready to roll.
It's like resistant. Like,
It's got a specific name. It's idiosyncratic reaction. That does occur. It does happen. And there's very little to no way to predict when it happens or how it's going to happen unless they can tell you it happens to me. Just so you're aware. All right. Now, what we're looking at.
How do you spell that?
Why are you going to let me do that? IDIOSYNCRATIC, I think.
I'm pretty sure it's IBE.
Is there an E in there?
I'm pretty sure.
I mean, I can go with that.
What's it mean?
It just means abnormal reactions. So like Benadryl normally makes people sleepy, but instead you take it and it makes you really wired. That would be an idiosyncratic reaction. Am I right? That's the first time ever. All right. And we'll hit on that just a little bit more when we get to the pharmacology. But anyways, so when you're looking at all these things are going to boil down to a couple of different ways. And so they kind of classify all the different ways that homeostasis can be disrupted, things that can booger us up. All right, hypoxia. Well, we know how hypoxia can mess up our homeostasis. You don't have oxygen, you lose half of your metabolism equation, right? All right. Nutritional imbalance. Well, there's your other half of your homeostatic balance and your nutrition there for your metabolism. Genetic diseases. All right. Once again, this is a broad umbrella. Sickle cell. That one's going to affect your oxygen carrying capabilities. All right. Von Willenberg's disease, where you've got a clotting disorder. You don't bleed. I mean, you don't form clots, so you freely bleed. So there's a lot of. Do I? Yeah, it's a form of hemophilia. It's a specific clotting factor, but for some reason that came in my brain before hemophilia did, so that's what came out. But there's a bunch of different things genetically that can affect how homeostasis happens. All right, cancer. All right, if you've got lung cancer, how's that gonna affect you? You're not gonna breathe as well, so that's gonna affect your oxygen intake. All right, physical injury. Anybody ever broken a rib? I haven't, but I've seen people who have, and they say it hurts pretty bad. Well, and here's the thing. Most of the time when you break something, they're like, hey, just don't use it for a little while, right? They split it up. You use your ribs every time you breathe. You can't not do that. All right, so for rib fractures, people tend to hypoventilate because take a big breath, it moves them more, it hurts more, so they take little breaths. And so they don't get quite that oxygen exchange that they normally are used to. All right, if you pop a lung, all right, there goes half of your oxygen capabilities right there. All right, if you get your leg cut off, if you break your femur and it pops out of the skin, like Ethan was mentioning earlier, problem. All right, toxins. What about toxins? Carbon monoxide. How does that affect it? How does that affect homeostasis?
It blocks your oxygen carrying capability.
All right, so it binds tighter to hemoglobin than oxygen does and says, get off, it's a big old bully, and it holds on tight, and it won't go anywhere, so then we can't tote oxygen, all right? Cyanide makes your cells think that they don't have any oxygen, all right? So they're not sitting there in line going, I need some, sir. Just keeps on trucking, all right? And then, of course, infections. Your body's putting its efforts into fighting that infection, and there's more stuff. We'll talk about that. But anyway, so a lot of different ways with your mechanisms, okay? And this is just touching the tip of the iceberg. There's lots and lots under each one of those, and we could talk all day about that, but, I don't want to. Y'all did a pretty good job of it. All right, there's some more examples. Hypoxia, narcotic overdose, diabetes, all right, fall from a second floor roof. He lands on a screwdriver, lacerating his liver. That's a bad day. That's like some Final Destination type stuff. Sometimes when it's your time to go, it's just your time to go, no matter what you do. All right? That's probably like, I'm going to trip on the carpet and break my neck or something. That's how I feel like that's how I'm going to go. All right, pneumonia, faulty gas furnace, carbon monoxide, bless you. That was serious. Was that a sneeze? That was, everything still okay in there? Just shake it loose a little bit. All right, environmental. All right, if it's 2 degrees Fahrenheit with 20-mile wind and you lock yourself out of your house, that sucks. You might be found when winter breaks. Mailman comes around and sees you standing there frozen. I would too, but not everybody's smart.
Like if it's really that cold, I'm not gonna walk 3 miles.
No, not in the least. Look, when I was probably like 25, 26, I lived in an apartment above a garage, and I came home when I'd been to the beach, and I came home and I couldn't find my keys to get in, and I was hot, and I was tired, and I was cranky, and I kicked my door in. I was like, I don't know. I'm and then I went and bought a new door and fixed the door frame, but I was just not having any of it, and there wasn't snow. I mean, just not gonna do it. Don't do hot. I might have a little more patience with cold, but not hot. Anyway, so most all of these categories of mechanisms, all those things there, and the dozens that fall under each sub-umbrella that we could sit here and talk about all day, are going to be classified as one of these areas. All right, and they classify these so you can kind of know, because typically your treatment for most of them are going to be on the same ballpark. They may not be exactly the same, but they're going to be similar, okay? So we have hypoxic, cellular, y'all say that, cellular, it might come out very well. Injury, say that whole thing, energy somewhere comes out of my mouth, I don't know why. All right, shock, impaired glucose utilization, electrolytes, and pH disturbances, environmental, all right, so those are your overall categories for ways things booger us up. All right, pneumonia. Let's pick something easier. Narcotic overdose. Okay? Could narcotic overdose cause hypoxic cellular injury?
Yes.
All right? So if you take away oxygen enough, eventually the cells will start having problems from it, right? Could it cause shock? Absolutely. Could it cause pH disturbance? Absolutely. So it can fall under easily 3, and if you accidentally got dusted like the prisons up north yesterday, could even be environmental. Have y'all didn't hear about that?
No.
So there was a prison in Chillicothe, Ohio, where some fentanyl got accidentally released in the ventilation system. I suspect, I don't think they've said yet, but I suspect somebody was smuggling in and hiding it in the HVAC, and then it just busted open and got spread throughout it. And they had like 20-something people, I think, that were treated for ODs. Between the prison guards, the medical staff, and inmates. And then there was another prison, Pittsburgh, Philadelphia, I don't know, some key thing, Pennsylvania, where they had an unknown substance that was causing patients to have signs of lethargy, sleepiness, etc., which is kind of like your early stages of most narcotics, so could have been the same thing. Which, y'all, there's more drugs half the time in prisons are on the streets. But, so I mean, could even maybe be a little bit environmental. You never know. But anyways, my point being that it's not always going to fall under just one category, and that's okay. Okay, so we're going to talk about all these categories. That's all we're doing today, is talk about these categories and what to do about them. Sound fun? It should. It's not. It is. It really is. I like this stuff. Now, adaptation. Somebody give me an example of how our bodies can adapt to a problem, to overcome it and not die immediately. Shivering, okay? So that would be some environmental. If you're cold, what does the shivering do?
It tries to warm you up.
It generates heat, because heat production is a byproduct of catabolism. All right, so generates heat, keeps you warmer, keeps you alive for a little bit longer, so you have time to bust in the window and get in the house. Or maybe if you're just adventurous, walk 3 miles with your neighbors. All right, what else? Sweat helps cool you off. I do that frequently. All right, my body's like, you're well insulated. You're going to stay warm. Sweat. All right, what else?
Speed up heart rate or
Increase heart rate, increase respirations. Bear comes in, tries to get your face off. You run. Your oxygen demand is going to go up because you're using your muscles. But anyway, so more oxygen, your body breathes faster to get more oxygen in. Heart pumps faster to move that oxygen quicker through the body. What else? That's a perfectly good example. Fever, all right? So all of those are actually short-term adaptations, all right? So So your body does short-term and long-term. Most of your long-term is more at the cellular level, okay? And has anybody ever known a smoker, or maybe was a smoker, has been a smoker? If you're not, don't start. It's not worth it. It's expensive. You stink. It's not fun. All right. So when most people start smoking, they cough a whole lot. All right. So and it's like, holy crap! Why do you keep going? It's cool, man. So they smoke and they cough a lot. Well, eventually, now inside your throat and inside your airways, you've got little finger-like kind of projections, and they're called cilia. All right. And so they're there, and they're doing it. I picture like sea anemones and like kelp under the ocean. That's kind of, I feel like that's what it looks like. But they're just moving, and they're catching debris and particles as they come down in your throat. Well, cigarettes have lots of debris and byproducts and toxins. And so when that goes in, they're trying to catch all of it, and they activate the Couch reflex to get it back out. Because we don't want it down in our lungs, because that's going to be bad for you. All right, so that's your body's short-term adaptation. But after a while, your body will try to listen to you. So if you just keep on smoking, you're like, don't do it, I'm not a quitter. All right? Eventually, your cilia will be like, all right, you're fine, I give up. And they'll go, oh, and they'll lay down. And now they're not doing their job anymore. This is why people who smoke long-term tend to have more respiratory infections, pneumonia, bronchitis, things like that. But, so then, that's a long-term adaptation. Okay, cells can change their function or their shape or things like that, so they can change type. And these are usually those long-term chronic adaptation things. Now, one thing, your body's really good at figuring out when you finally came to your senses and stopped smoking, and so after you quit, you'll cough worse than you did when you smoked for a couple of months. And then that's all the cilia coming back to life, like, oh, we can do our job again. Like lights shining down, halos, and I don't know, harps playing in the background or something. So then they start moving, and that's what makes you cough even more again. Eventually that will go away. But that's your long-term adaptation. All right? Now, this is breakdown of different types. Atrophy, which just means it's getting smaller. They're shrinking in size, okay? This is like long-term weight loss or things like that. Or like Clay, he's had his arm in a cast for the past 2.5 months because he broke his arm in half. And he's already kind of shrimping to begin with, but this little arm, y'all, it's even shrimpier. Like, I can put my hand around his bicep. He's nothing but skin and bare minimum muscle because he just hadn't been able to use his arm for the whole summer. He broke his arm 3 days after school got out. And he got his cast off 3 weeks after school started. So, you know, that arm is like chopsticks over there. All right? Metaplasia, this is a change in the type of cells. This is common in cancer or chronic, or things like stomach acid, where you get chronic GERD. The cells that line the esophagus near the stomach will actually change type, so they're more resistant to that stomach acid. All right. Hyperplasia, just increase in number of cells. Hypertrophy is increase in size of cells. Anaplasia is loss of cellular differentiation. When you look at cell tissue under microscope, you should be able to tell what cells are what type. They should be individual different types of cells. All right? When they all change into the same looking thing, that's bad. That usually means tumor growth, something of that nature. All right? Dysplasia is where you have cellular maturation is delayed. And basically, this is abnormal cells, but they usually call it more like precancerous cells. So something's changing them, but they're not, you know, it's not cancer yet, but they're not normal. Keep an eye on it type deal. Okay? Neoplasia is new cells, new growth where it's not expected. You know, most people, like your face for the most part, is done growing. You know, it'll change a little bit as you go, but if it all of a sudden like just starts growing, something's going on. All right? And then apoptosis, this is self-destruct. So that is where something's gone on and the genetic encoding in the DNA has been changed, and instead of reproducing and making new ones, it starts killing itself. Well, that's a problem because we don't have new skin cells being made. What's eventually going to happen to all our skin? Don't go away and we look really weird. All right, so as far as cellular adaptation, I want you to know, like, you know, if you see metaplasia, okay, meta types, lots of them, all right, atrophy, that's reduction in size. Be kind of familiar with them, but you don't have have to be able to give me all of that. All right? But I'm more concerned that you know this is a way of long-term adaptation by the body. Okay? Now, when we're talking about hypoxic cellular injury first. Okay? Got a couple of different phases that you're going to go through, and they kind of line up a little bit with your phases of shock. All right? Your phases of shock, what are they? Compensated, decompensated, and irreversible, right? So this type of stuff is going to kind of fall along with that. So ischemia is a term you need to know if you don't know it already. And ischemia means a lack of adequate perfusion to the tissue. Okay? Lack of adequate perfusion. You may have heard it in regards to myocardial ischemia, all right, which is just a big scientific medical terminology way of saying chest pain, you know, potentially a heart attack. All right? So, with that, anything that results in a lack of blood flow to the tissues that results in hypoxia could be considered ischemia. All right? So, what we're going to do here is we're going to try to reverse that ischemia. Because if we catch most stuff early enough, we can fix the problem, not lose the tissue or the person. All right? So, we're going to try to restore perfusion. We're going to make sure they've got adequate ventilation and enough oxygen. We're going to hit it from all three sides, ABCs. Okay? Now, and I need to change the wording on that last part there a little bit, but remember we said, you know, with their aerobic and anaerobic metabolism, the ATP and all that fun stuff, we stay in anaerobic metabolism. When oxygen is there, we go to the next step, which is your aerobic metabolism. All right, then we progress on, we take our pyruvic acid and change it, take it through the Krebs cycle, and then we end up with water and CO2, all right, which we know we can get rid of a lot easier than we can get rid of pyruvic acid, okay? We can hang out in aerobic metabolism for a little while, 5 minutes or so, without any long-lasting effects, okay? But after that time frame there, 5-10 minutes or so, that's when you start having more long-term problems, and it starts getting a little bit harder to bring us back from that injury level. Does that make sense? You know, the earlier you can catch a problem, the easier it is. Your grades. Y'all, what happens if you never look at your grades, you don't turn any of your work in until like the last week, and you're like, oh crap, I'm failing. All right? It's a lot harder to try to pass anymore, right? Same thing kind of here. If you stay on top of it and you find the problem early and address that problem early, most times you can get them back from the brink of death. Same thing with your grades. Stay on top of it, you'll be fine. Get behind, it's going to be bad. All right, so hypoxic cellular injury. Anytime oxygen to the cells is disrupted, we know we have to have oxygen to produce the energy with our ATP, right? Without the ATP, we cannot do sodium potassium pump. We can't do any of our other base processes that we have to have. All right, that cellular edema, that's just the cells getting more water in, and then they pop, they die. And then enough cells die, tissues die. Enough tissues die, organs die. Organs die, we die. All right? That's how shock works. Cells die, tissues die, organs die, we die. There's your apoptosis process. This is where that self-triggering when the cells are damaged. Just the nice little picture there where it shows kind of how things break down and self-destruct and blow up. All right. We've talked about that a fair amount. Does everybody feel, honestly, do y'all feel fairly good about aerobic metabolism, anaerobic metabolism? Have any questions about it? Tell me what you think you know.
I don't really know what I don't know.
So we're in that.
Just kind of threw off my. I don't know what to. I don't know what to.
I mean, I'm not trying to be like put you on the spot, but I mean, just seriously, if there's any, I want to make sure that you understand it.
So aerobic metabolism is the backup.
It's not the backup, it's the goal. Let's say you sign up for a 5K. I don't know why you would do that, but let's say you do. All right? They have a 1K stop off if you get tired. All right? So you're starting with the goal. We're going to run the whole thing. But you get started and you get like shin splints or a cramp. and you're like, I can't do this, but I'm going to get something done, so you get to the finish line for the 1K, and you're like, yep, this is where I was going the whole time, and you're done. All right? You wanted to get to the end. It's better to get to the end, but you're going to go at least that far. Does that kind of make sense? A little bit? So anaerobic, all the time. Okay? This gives you 2 ATP and pyruvic acid. Not very much. Can't get rid of it easily. So if we just left it here, we wouldn't last very long. But this is the starting point. You got to have this to do the Krebs cycle. All right? So add some oxygen to it. Okay? And Krebs cycle. All right? And then that gives you aerobic metabolism, which gives you 36 ATP, and what else does it give us?
Lactic acid.
H2O and what? CO2. All right, so this we can do something with. 36 ATP, way more than 2.
That's the 5K at the bottom.
Yes, this is the 5K at the bottom. H2O, we can easily get rid of it. CO2, we can easily get rid of it. All right, so this is the goal. This is the most beneficial for our body. We can hang with this for a little while, 5, 10, 15 minutes, depending on what's going on. But our yield's not that great. It's a whole lot of work, and then you get very minimal reward. You bake a big pan of brownies, and you give them all away, and you get one. But you spent all day working on the bad boys. I would be upset. I want my brownies. All right? And you have pyruvic acid. You got a hot mess in your kitchen now. All right? Can't easily get rid of it. But you can go ahead and sweep it right over here into aerobic metabolism, add some oxygen. It takes it through the Krebs cycle. Now you've got good yield and things you can easily get rid of. So it's much more efficient.
So you want to get that
Yes, our goal, and most people, you boom, bam, you do it. Unless you don't have adequate oxygen or glucose.
So that's when you're in anaerobic.
That's when you revert back to your anaerobic metabolism.
So basically, if there is any type of like respiratory issues or low blood sugar, you're basically in anaerobic.
When you run out of adequate stores of oxygen or glucose, you're hanging out in your anaerobic.
Before you die.
Before you die.
Okay.
Yeah. And so then the problem with this is you don't have as much energy, so you're not going to be able to sustain it as long. And you've got to build up a pyruvic acid that we can't easily discard and get rid of. So that's going to affect the pH, which is then going to not only be under cellular injury, it's also going to throw off the pH disturbance. So it's a double whammy. And it's just like a big old snowball rolling downhill. It gets bigger and bigger and affected more and more different things, all from the cellular level.
Someone in kidney failure along with COPD is anaerobic.
They're probably going to die soon if they don't get adequate treatment. And you can have certain degrees. You may be running with aerobic most of the time, but you don't have quite enough to meet your needs. So you hit this when you can, and then you back up with this when you can't. And then you come back in with some oxygen, you put back on your oxygen, sit down for a little while, and it kicks you back over here because now you got enough oxygen to meet your needs. Kind of make sense? All right. But anyway, this, reverting back to that, is considered to be a short-term adaptation because it only will last for a little while and it can't keep you sustained forever. All right, now, in order to have proper oxygenation of cells, you got to have a couple of different things. Wait. Sorry. All right, you got to have a couple of different things in order to have proper oxygenation to the cells. The first one you have to have adequate onloading of oxygen to the hemoglobin, okay? So what all does that have to have? In order to get adequate amounts of oxygen on the hemoglobin train, remember, choo-choo, little train, all the little train cars, the hemoglobin going through the body on the track, all right? You have to have enough hemoglobin, right? Because you can have all the oxygen in the world coming in, but if there's no hemoglobin, what's going to happen? It's not going to bind, right? It's pointless, right? That makes sense? Okay. You also have to have adequate oxygen, right? Because you can have all the hemoglobin there, but if there's not enough oxygen coming in, there's nothing to diffuse. Does that make sense? All right. So in order to have that one thing, you've got to have adequate hemoglobin. You've got to have adequate oxygenation. In order to have adequate oxygen, you've got to have an intact respiratory drive. So your brainstem has to be working. Your phrenic nerve has to be working. Your diaphragm has to be working. Your lungs, your thoracic cavity have to be working properly. Okay, so all these things have to be lined up working just to get oxygen in and on the hemoglobin.
Okay, this might be a stupid question.
What's up?
But, okay, like, you get 2 ATP anaerobic, I know that, and then you get 36. But is it like 36 more, or is it like
36 total.
Okay.
And it costs, I don't remember off the top of my head how many it costs to go through the Krebs cycle. If anybody knows, feel free to throw it out. But it costs a certain amount, but then it yields you X amount.
I think it's 4 or 2. It might be
Well,
2,
on anaerobic, it costs you 2 ATP to do it, and you get 4, but then it costs you those 2, so you only end up with a net plus 2 after the anaerobic thing. So it's not very efficient. It costs as much as you get. It'd be like you get a bank account and you put $5 in and they charge you $5 fee to have the account, or $2.50 fee. I don't know. It's just not very effective, but it's enough to keep you going for a little while. All right. So everybody good with the adequate onloading of oxygen? Okay. All of those processes have to be working and in place to get oxygen in and on the hemoglobin. Can you help with this at all? When? How?
If they're not ventilating on their own.
All right, so if they're not ventilating on their own, if something in that control center is messed up, brain, spinal cord, whatever, we can put the oxygen in them. Absolutely. Can we fix the hemoglobin? No, not really. That's going to be one of them diesel fuel or gas and roll, because we can't fix that. All right? They need a blood transfusion. Okay? Circulation of red blood cells through the microvasculature to perfuse the tissues of the body. You got to have enough blood and enough vessels to get it through the body. You got to have the tracks. You got to have the train cars. All right? Train's not going very far if you don't have tracks to ride on. Okay? So, can we do anything about that?
Well, if they're not circulating, we can provide.
If they're not circulating, we can provide the circulation, right? We can do compressions. All right, that's the other part of it. You got to have the pump. Maybe what's the engine? Is it engine? Thing that goes choo-choo? I don't know. I'm not a trained person. So you got to move the red blood cells. You got to have the red blood cells. What if they're leaking out? What if the tract has been disrupted and it's leaking out somewhere? Stop the bleeding. So you can basically help the body, give it time to clot up and stop that bleed. All right? Adequate offloading of oxygen to the tissues once the red blood cells reach the microvasculature, which basically just means capillary beds. All right. What's going to affect that? pH. This is that pH. Remember we kind of touched on it yesterday, where that oxygen hemoglobin dissociation curve looked kind of like that, where this is the happy spot and it gets to where it needs to go. It makes it to Atlanta. All right, if that pH gets too low, too acidic, it jumps off early. They make it to like Noonan. All right, if it goes up and it gets too high, they stay down too long, and so then they make it all the way to Savannah, and so you bypass your goal. All right, so that's the pH is what's going to affect your offloading. That's why everything else is so important with that pH. Not breathing appropriately, that's going to affect your pH. Okay, all these other things go back and affect that pH disturbance, which then is going to go back and affect the hypoxic cellular energy. So literally, shock kills you from cell up. Everything starts at that cellular level, and then when enough cells die or get injured, then that tissue starts dying or gets injured, and then the organs, and then us. All right? Our primary goal is to stop that. Intervene, stop that, and fix the problem so that the body can kind of fix itself. All right? Here's just a nice little picture of your gas exchange. It's a better picture than I drew yesterday. But you got your alveoli, look kind of like grape clusters, got your capillary beds over it, and then you've got your gas exchange through those capillary beds where you've got oxygen coming in, getting on the hemoglobin, carbon dioxide offloading through the diffusion, right? Remember that? Yes? Okay. Now, when we are looking at all of those different things, they're going to break it down, all these different ways that can affect the distribution of oxygen to the cells. Okay, 4 different ways. Oxygen delivery to the bloodstream, oxygen transport within the bloodstream, oxygen transport from the bloodstream to the cells, and utilization of the cells. Okay? Y'all want to take a quick break? Y'all ready? All right, y'all go take a break. Take like 5 or so. I've got 9:46. I didn't think he would do that.
Oh, I was like, what?
Is that any better than the pull down or
Yes.
worse?
It's better because it cuts the pull down cuts it off.
Mm-hmm. That the glare was, which one was?
I said, two things there, so it's already.
You better shut up.
Hey, you never let me know about that.
Alright. Do you have Elsie ready, you said, as well?
I do have that.
I think they will do the full test.
But me and Cindy both done that one, and they keep it the same.
You did, okay, alright. Did you do the PhysStat test 2 times?
And I did the results and something like that. I'm glad I got
You got thumb drop?
Home job?
not on. You got one?
I'll give you some study material stuff that I have, just to look through. The biggest thing is know the normal. Like know the normal so you can recognize, and don't, when you're looking at it, don't just immediately like, oh, I know what it is, skip through it. Like read the entire question, don't look at the answers. Mm-hmm. Like read it, and
I
just
can
test in
process
general.
elimination.
Like read the
There was
question.
2 completely wrong ones.
And usually you'll have 2 that are absolutely wrong, and then you'll have 2 that are like one's right, and then one's like. It's
But it's
what they call a
kind of
distractor.
Yeah.
But
Don't feel bad
read the
about that.
question.
I already did fill the first time.
I failed the first time. I got done with mine like in 10 minutes.
Read the question and then answer it in your head. Like think, okay, what is the answer to this? Don't look at the answers. Just think, what is this? And then look at the answer and see which one lines up with what you were thinking. And read very carefully because like but or things like that can totally change. And don't ever base like say question 1 is about yada 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 whatever. And then question 5 is a similar situation. Don't base question 5 off of what question 1 was because there's going to be something in there that differentiates and makes it a different situation.
What helped me is when like you know how we had the medical and protocol.
Yeah.
The way it was, like what the question is like, okay, well, you know that the scene's safe and okay, you know like alcohol. You just gotta figure out where
the correct answer will follow the order on that sheet. So if there's something that's out of order, even though it may be all the right parts, if it's put together wrong, it's wrong. There's going to be one that's going to be, let's say you got somebody who's not breathing. All right, so your correct answer is move the needle that's hanging out of their arm, provide ventilation assistance, load them up and transport. And then you see another one that says bag them via BDM at 15 liters, secure them, load them up, transport. And so you instantly go, we're going to bag them, so that's right, but it didn't allow for scene safety. Does that make sense? And so if you, but like she said, if you go down that sheet and literally like have that sheet in your head, so when we go in there,
I think that's what helped me.
scene safety, and then go through your ABCs.
Second time I did it. Second time I did it.
So with your CAB, that's a very good question. Well, hold on, with your CAB, if they appear to be so basically that's what's unresponsive, and you don't see any respiratory effort, if they have so that's really what snoring respirations, I didn't go in all the way. Slow down and actually digest it and think about it for a moment, then move on.
Everybody that's going to walk out. We had to go on a cruise for her to de-stress. She literally came back from the cruise, had to stress the next day. She didn't think about it that week before. She was doing, other stuff. I was like, she was able to feel about
And like, it's like a plant stuff that will expand your skin.
I sent you another one after I sent you one saying I asked them. I sent another one back saying I heard back from them. They said yes.
I'm kind of afraid to do a podcast thing.
They will after September, I think. Here's I found out why we can't do anything. So there's a prep class going on. There's alternate doing their EMT class. And so they've got before they do the ER. So they basically got all of the ERs for Saturday and Sunday for September. So they're already full. But October should be fine.
Yeah, because they started August 13th, so they didn't start.
So the ERs, we need to put October date?
I mean, if you have other dates you can do in September, if you don't want to do, if you can do like a Monday or Friday or something, that's
I
fine.
mean, I can do Friday, Saturday, and Sundays. I can't do Mondays and Friday.
If you want to do some up, put them down.
And do I need to put 9-8 on here for that or?
Maybe write a note at the bottom and put it and just put like a little star and that.
For our respiratory clinical, do we have to do that East Alabama?
You can do it at Russell or Clay County.
Okay.
So if you'd rather go to Alex City, then that's fine.
Yeah.
I'll have to find out the time on theirs. I'm not 100% sure on their time frame. But yeah, either one of those are fine.
So, like, for these dates, like,
Mhm.
kind of right beside ambulance, and then, does that make sense?
If you want those, I will try, but I can't promise.
Right. I know I'm being a little complicated, but it's like because of shifts and all that crap.
And
So,
if there's put a little star by it, if that like you don't get off shift until 8 that day, then
well, we're supposed to get off at 7.
Yeah.
Go in at 7, get off at 7.
so you can't do an ER that day because they start at 7.
That's what I was trying to do.
Yeah.
Nights.
Yeah, that's fine. Just put a little star by it or something.
Okay.
What I'm probably going to end up doing, y'all, just because everybody's got little things that they need done or want done, so demanding. Probably just going to have y'all sit in one day. Like, I'll pull you out one by one in lab or something, or stay over a few minutes and just sit down and plug them all in and get them done, so that way y'all have maximal input, and hopefully we can get it all worked out that works best for y'all. What do you mean?
Like, East Alabama, they're going to call Mr. Simpson.
Oh, yeah. Well, here's the thing. If I put you down for somewhere, then I'm holding that spot for you. So then when the EMT classes go to look, that spot's full for them. So they have to change their schedule to go to other days that are still available. Does that make sense? So I don't like changing. And at 1 or 2, if something happens, I realize life happens. It's not that big of a deal. But, there's that little asterisk there that says you may not get your first pick if you have to reschedule. All right, especially once everybody else starts putting in theirs as well. I'm trying to get y'all in before they do, so that way y'all get a little more freedom there with your picking, since y'all have to do more. I don't really mind, but I don't want to schedule you, if you know in October you want to try to get this done, I don't really want to schedule you a whole bunch for like ETS or somewhere else, and then when you know you're going to want to swap it. I would say find out where they're at with the contracts, but things move slow. And it's got to come in, get our dean's approval, go up, get the president's approval, get post-secondary approval, come back down. And so it may not even be this semester. I would say probably would not bank on it being this semester just because things move slow sometimes.
Yeah, I was just wondering.
Yeah.
I know I talked to Steve about
Now if it does come available and it does happen, and you've got one shift left and you want to change it over, I'm perfectly fine with that.
When can we expect to be scheduled? When will
I will not do
it
any
back?
scheduling until you're checked off for
Okay.
your skills. So the earliest will be September 11th, I think, 12th, somewhere right around there. My goal is to get everybody in and checked off on those days for your preliminary checkoffs, so that way I can spend Wednesday scheduling or Tuesday afternoon scheduling, and then I can have you a schedule hopefully by when you come to Career Expo or the beginning of the next week.
Yeah, preceptor I want to use at Montgomery.
Mhm.
About to have babies soon.
Mhm.
I was wondering if I can check off sooner so I can.
Is it Amanda? I mean, if you are comfortable and want to go ahead and check off Tuesday on them, I'm perfectly fine with that. Just let the preceptor know whoever's in there with you.
That we went over?
Yeah,
Okay.
yeah. But you still got to get your peer evaluations too.
So can I just do my peer though, then go around and check off?
Mm-hmm.
If we get out early today, can we practice the lab?
If you want to. Okay.
Do you have our sheets
Yeah.
that we wrote all the dates on the meeting?
They're up here somewhere.
I just can't change the date. I forgot.
All right, just hang out afterwards and I'll get it for you. Somewhere up here. We'll find one.
We can find it and have it. Because
Yes.
I kind of goofed mine a little bit. Like,
It happens.
I just don't want to turn it into you considering like, oh, she's an idiot for sure.
That's fine.
I do not think anyone of this place.
Yeah, we're gonna do. It's just a lab where the preceptor's evaluating you.
Okay.
Same thing you've been doing. It's just they're watching, make sure you don't hit any of the critical criteria. Basically, make sure you aren't going to go off and kill somebody. You don't have to be perfect yet, but you just can't kill anybody. I have faith. I have faith. All right, let's roll on. Yes, ma'am.
Can I just write what? I know that's for ER. Can I just write like the same dates? I don't want to write all these dates in.
You might want to pick some more dates.
That's like,
But here's the thing. Here's the thing. You've got at least 3 ambulance clinicals. You've got at least 4 ER clinicals. So now we're up to 7 individual days. You've got respiratory, so 8 individual days. Okay? Which doesn't sound like a whole lot. But let's say that on your first day you go look, it's already full. There's nothing available on that day, which happens very quickly. All right, so then you've got 10 days listed. Now we're down to 9 days available for 8 shifts. And then I go look at your next day, and dadgummit, it's full too. Now we've got 8 shifts in 8 days. You better hope that those are all available. Do you see what I'm saying? That's why I get y'all to go ahead and fill it in.
well, I only can work Fridays, Saturdays, and Sundays. I have
Which
to
is
work on them.
usually what most everybody else has too. It gets rough.
But that's from 9/14 all the way to our last days. These are all these days.
Well, just hang on to it. Hang on to it. Look and see. Dig deep. See if there's any more days. Think, kids, keep in mind too, y'all. We got Thanksgiving break. You got, other. You get a day off, I think, for Labor Day is not. We're not gonna be cleared yet.
Oh,
But-
I can write 1 day on each line. I wrote like 3 days.
No, write 1 day on each line. Bless it. All right, that's the only thing. I'm just gonna have y'all come in and sit with me, and we'll powwow, and we'll get everybody in and scheduled. That way, because I know everybody's got little different things. All right, let's move on.
Let's do it. No more breaks.
Yeah.
No more breaks.
Who said that?
She's getting crazy.
That's what we
We
can get.
literally are on slide 22 of 77. You can see here the 50 slides.
I talk a lot.
It's okay.
Well, that's what we
All
can
right.
get through so we can practice.
Oxygen delivery to the bloodstream. Give me an example. How is oxygen delivery to the bloodstream? How can that be interrupted?
If you start,
If you've got a blood clot, if you're bleeding, all right? Can we fix a blood clot? No. So what is that going to require on our part?
High flow diesel.
Recognition that, oh, you might die. That's not good. All right? Maybe some prayers if that's just so you're so inclined. Maybe a helicopter. Why would a helicopter maybe be an option?
Because it goes nowhere.
Because they can go a lot further, a lot faster than we can by ground. So they may get them there within that window to maybe save them. So knowing your resources, absolutely. All right, so if it's bleeding, can we fix that?
Yes.
Maybe. If it's internal, not so much. But if it's external, locating it, realizing it, and going and doing whatever you got to do to fix it. All right, but that all requires you recognizing the problem. All right? All right. Oxygen transport within the bloodstream. Sickle cell. Can we fix sickle cell?
No.
But can we improve the oxygenation to help basically load up their bloodstream with as much oxygen as we can to be available to bind if there happens to be a normal hemoglobin protein?
Yes.
Absolutely. All right, so sometimes we may not be able to fix it, but we can try to adjudicate it and make it a little bit better. Try to make it not quite so bad. All right, oxygen transport from bloodstream to cells. That one, for the most part, is going to roll back to that pH. Can we affect their pH?
Yeah.
You can. Ventilatory, if it's DKA, different things, and we're going to hit on that, but your different things that can affect your pH, some of them we can affect. Or sometimes, if you're not doing things right, you can actually cause a pH imbalance, which makes the whole thing even worse. All right? And then oxygen utilization by the cells. Not a whole lot we can usually do with that one, but recognize that there's a problem. All right? If it is something like cyanide or something like that, then there is an antidote. It's not required in most places, though, so you may or may not have it. But just recognition. All right? Most of the time, improving the oxygenation is going to help, and then do whatever you can to assist with these other ways that it can be disrupted there. All right, so oxygen delivery. We know the atmosphere has adequate oxygenation at most normal levels of atmosphere. All right, You also have to have ventilations that produce adequate tidal volume and minute volume to provide enough oxygenation. How can we ensure that?
If necessary, bag valve mask.
BVM if needed, but you're looking at rate and volume, right? We're no longer just looking at rate, all right? We're looking at volume, which is shallow respirations or deep respirations, but also quality. That's the quality part of it. So we're not just rate, but we're looking at the quality of it, because they may have a perfectly fine rate, but it's shallow, so they're not getting enough oxygen. So it still needs to be assisted. When we're looking at ventilations, we're going to break it down, and we're going to evaluate to see if it is adequate. I don't know if that's how you spell it, but that's what we're going to spell it. All right? If there is any kind of distress, if they are in failure, or if they are apneic altogether. Okay? Failure, most people tend to think of that as absence of breathing. But in reality, respiratory failure just means, for whatever reason, we don't have enough oxygen to meet our body's demands. Okay? Usually it's going to be a problem with that quality or rate, one of the two. But you can still be breathing. All right? So just because they're breathing doesn't mean they don't need assistance with ventilation. Does that make sense? Okay, don't be afraid to help them. Now, if they start pushing you away, and they're like, oh, I'm good, maybe not. All right? Now, as far as oxygen delivery in the blood, okay, if you've got atmospheric pressure, partial pressure of oxygen is decreased. If you're up in like Pikes Peak, whatever it is, up in Colorado, I think it is, like the tallest place, 14,000 feet or something above sea level, I think. I don't know, high. All right, the oxygen much thinner up there. You don't have as much available oxygen. It can cause like high altitude cerebral edema, pulmonary edema. And has anybody ever been out west or been up really high in the mountains? What happens when you get out there at first? Ears. Well, it's colder, but usually people get really tired. Like if they're just trying to go about their business doing their normal stuff, and like normally you can walk around and shop all day long, and you get there and you're like, I've only been to 2 stores and I am whooped. All right? It's because your body hasn't adjusted to that lower percentage of oxygen. You live there long enough, your body will eventually long-term adapt and adjust to it. All right? As far as airway obstructions, that foreign body airway, okay? If O2 can't get into the lungs, it doesn't matter how much is available around you, it's not going to be able to diffuse. Makes sense, right? All right, neurological impairment. Remember that I said that all those things have to be lined up in order for this to happen? This is addressing that brain part. So if the pons, if the medulla, if any of that in the brainstem that normally sends out the signal that says breathe is not sending out that signal, then you won't breathe. You don't breathe, you don't get enough oxygen, right? All right. If you have the chemoreceptors, those are located, remember, aortic arch area and the brainstem and the measuring CSF. If those are messed up or misinterpreting information, the brain may be working fine, but it's not getting good information. It's not getting good intelligence, so it won't tell you to breathe. All right? Maybe the chemoreceptors are working fine, the brain's working fine, but the phrenic nerve is severed because of a car wreck or something. Okay? Phrenic nerve gets severed. The impulse, the travel way that the brain sends down to the diaphragm to constrict or contract, pull down, decrease your pressure, and then makes you physically breathe. All the other stuff may be working, but that phrenic nerve is disrupted. Its impulse is going nowhere. All right? It's like a dead end. All right? And then, of course, the diaphragm itself. If the diaphragm, for some reason, is messed up, which that's usually not the problem, but if it is, then all the other stuff could be working, but the diaphragm doesn't contract, then you don't create that negative pressure in the chest, and then you don't draw in a breath, so you don't get the oxygen in. So all of those things have to be working in harmony together to get it oxygen in the body to be available for the next steps. All right? And chest wall, that's the other part of it. I didn't mention that one. So chest wall, remember that thoracic pressure? When that diaphragm contracts and pulls down, it creates a negative pressure, which is going to draw air in. If that chest wall is not intact, it's not going to create the right pressure. And so then you're not going to get adequate amounts of oxygen and air coming in. Okay, you may still get some, but you're probably not going to get adequate amounts for very long. All right, alveoli. Alveoli have to be at the capillary beds for gas to diffuse. And when I say close, I mean, think of it kind of like this, kind of like a spider web almost covering around them, okay? They've got to be right there together because diffusion is fantastic, but it can't cover a football field. That's not going to happen. All right, so they've got to be close. What are some things that you can think of? Well, they're up there, never mind. There's some things that could actually cause this to not happen. Pulmonary edema, what's that going to do? You ever try to breathe underwater? How well does it work? Not, right? We don't diffuse very well through water. So if you've got fluid built up in those alveoli, that's literally putting distance from the oxygen coming in the capillary beds. They can't reach to it, okay? If you've got pneumonia, mucus, you got mucus built up in there, an inflammatory response, and that's literally putting distance. It's narrowing the bronchioles, and it's putting distance between the oxygen coming in and the alveoli and the capillary beds. All right, bronchoconstriction, they're getting smaller, right? You ever try to breathe through a tube? Like a straw? What happens? It's hard, right? It's number one, it's physically harder to draw the air in and out because it's smaller. But if you do it long enough, you're like, I'm going to get this down. You get lightheaded, right? That kind of lightheadedness is because of lack of oxygen. It means stop, or else they will put you to sleep, make you stop on your own. All right, but that bronchoconstriction makes it a lot harder to get adequate amounts of oxygen and air down to the alveoli where the gas exchange can happen. All right, anaphylaxis, COPD, asthma, those are your most common causes of bronchoconstriction. How can we recognize bronchoconstriction? Any ideas? Wheezing, shortness of breath, and capnography. Capnography is a wonderful tool for recognizing because it displays a very classic bronchoconstriction pattern, which we'll hit when we get to the respiratory chapters. But so all those things. Now keep in mind, wheezing is like that kind of hallmark of, oh, hey, bronchoconstriction. But what happens when they close off so tight that there's really no air, no room at all for air to go through? Are you going to have wheezing? No. You're not going to have much of anything, right? So don't count absence of wheezing as not a problem. Does that make sense? Evaluate the whole picture and look and see, are we moving good air? Okay? Surfactant. Surfactant's kind of like the surface tension thing, and that's what keeps the alveoli kind of springy and intact and not all shriveled up and collapsed on themselves. All right? This is why babies who are born before 26 weeks often have a very difficult time, because that's about when surfactants formed in the body. But the surfactant, with that, really, usually your most common ways that's going to be an issue is drownings. Like if you get water inhalation or something like that kind of washed away, that may cause some issues there. All right. Can we do anything about that?
CPAP.
Some of them. Transport. For surfactant, there's nothing we can do. All right, but bag them if they need it and roll on. Keep positive pressure, try to keep the alveoli from collapsing further. Bronchoconstriction, you've got a medication you can give. CPAP can help force it down in there if they're really tight. If they have pulmonary edema, CPAP can help push that fluid back through. All right, so there's a bunch of different stuff you can do there. Now, shallow breathing, obviously, inadequate ventilation, you're not getting enough actual volume of air in there. Now, VQ mismatch is just a kind of a weird term, but all that means is that in normal circumstances, your ventilations and your perfusion are both good, and so they match up, okay? But this means your ventilations are good, but for some reason, the perfusion's not. So it's a VQ mismatch. I don't know why they call it that. They do, all right? So one part of the equation's working perfectly fine, but the other half's not here, okay? Y'all all come to class, and no teacher shows up. I'm not here, and I don't have somebody in my place. Y'all all showed up and did what you were supposed to do. But are you going to learn anything that day about this? Nope. Probably not much, right? Is it your fault? You did your job. It's the other part of it, okay? So it's one part of that equation. Either way, though, if the problem's not fixed, you're going to end up going to respiratory failure, and then respiratory failure leads to shock and respiratory arrest. And we all know respiratory arrest. What are y'all passing around? Gum? It's like passing notes like in high school. So y'all gonna have some fresh breath. All right. Now,
Ventilation is working fine, but what
one part of it. So in order, normal, good respirations, respiration ventilation requires good ventilations and all that entails, and good perfusion. Hang on, I'll run out of spray. Alright, so most of the time you've got both of those and it leads to good perfusion. But if you don't have one of those, you're not going to have this. Basically, it's saying it doesn't equal up. Alright? Your ventilation may be alright, but for some reason that respiration's not okay. Something's not matching up to give us the good perfusion. Organ transplant or transport in the blood. You've got to have enough circulating blood volume, right? What's our average amount? Average adult? 5 liters-ish. All right, if your normal's 4, then you need enough to perfuse, close to 4. Can you get away with 3 for a little while? Absolutely. Can you get away with 5 for a little while? Absolutely. Can you get away with 1 for very long at all?
Nope.
Not really. All right, so it's all relative to how much you're losing as well. This is why you can give blood. Speaking of which, they're doing a blood drive, I think today and tomorrow over at Opelika. If you go give blood and bring me back and show me like your t-shirt or something that you get for doing it, I'll give you 5 points on one test, not the final.
Don't you have to weigh a certain?
100 pounds, I think.
110.
110? That's never been an issue for me, so I don't really know.
What if for some reason like your body like they won't?
Yeah.
But you have to bring back, I guess it would have to.
Then see if you can take a selfie in the bus.
So I think it's
Something that shows me that you tried.
I was gonna get any black.
They're probably like, you're too light. Sorry.
Don't poop and eat up. Just hold it in. You can have 5 pounds up in there. Just hold it in. It's on the honor system. I don't know. I mean, they've never asked me. I just kind of figured they looked at me and were like, no, she's good. Not 110. I don't think that's a problem.
Yeah, they always ask, and you can tell them how much you weigh, but it's not like they ever really know.
My driver's license says I'm a whole lot less than I really am. They don't maybe get old scale there either. All right. It's today and tomorrow, I think, over there on Opelika campus. So if you can go give blood or try to give blood or something, and if you like already know you can't give blood due to whatever reason, you ain't got to tell me. I don't know, if you want to write something, tell me why giving blood's a good thing, then that'll suffice too.
So you need an essay on why.
Yeah. Okay. You can give your blood or give your time.
So it's really about it's against my religion.
Really? And that precludes you forever? I mean, theoretically, you shouldn't be getting rabies, so I mean, that shouldn't be a problem. That's really bizarre. I'm going to have to look into that, and I'm curious now as to why that would preclude you.
Because I tried like 2
Yeah.
years ago, and they're like, "Well, have you ever had like you get through that list?" And I was like, "Oh, I had those rabies shots." So like, "Oh, I'm sorry."
That's weird.
Those questions are crazy.
Have you had sex with a person who's had sex with a clown midget in Africa in the past year? Like, I don't think so. I don't know.
So some like medicine, some of the allergy medicine that I have to take,
Mm-hmm.
I can't get blood with it.
Really? Well, if y'all want to write me a little thing about why it's good to give blood, if you can, I'll give it to you. How long does it take you to give blood? About 30 minutes?
Paragraph 5 to
A good solid paragraph. I'm talking like,
7 to 12 sentences.
That's like half a page.
yeah, like half a page minimum. It ain't got to be a dissertation. I don't need 20 pages. But I need at least a solid, good, no double spacing if you're doing half a page, because that's cheap. That's like 3 sentences if you're good. I'm really good at that. And it would sound so good, and there would be nothing there.
Most times I'm gonna get blood.
It's probably easier just to go give blood if you can.
I'm going to try.
You want to try? I have faith in you.
Try it
You
tomorrow.
can do it. All right. Now watch them when they go stick you.
Oh, God.
Like, check it out and ooh, that's a big needle.
I do it.
It's about a 14.
16.
Is it 16? It's pretty big.
I'm plasma.
Freak out.
It's huge.
It's not that bad.
If they're good though, it doesn't hurt that bad.
Yeah.
Then you just sit there and squeeze the little squeeze thing. Anyways, we're way off track. I just remembered about the blood drive and we'll tell you about that, give you some opportunity for some points. All right, adequate hemoglobin level. All right, hemoglobin. You got to have adequate hemoglobin. You got to have adequate red blood cells, adequate protein, adequate iron to bind the hemoglobin to the red blood cells, right? Correct biochemical conditions. That's all the chemistry part of it. All right, if all that's intact, then we're good. We can't really do much about that part of it. All right, but just know that that has to be there in order for oxygen to be transported throughout in the blood. All right, anemias, we talked about those earlier. Acidosis, alkalosis, we talked about those, that oxygen hemoglobin dissociation. All right, cardiac arrest. If the pump's not pumping, it's not moving, no matter how much oxygen is there and how much red blood cells are there and how much hemoglobin is there, right? It's not moving, it's a standstill. All right, that's why we do CPR. Some other terms, and the reason I've got these in here is because they tend to pop up on registry for some reason. But SCA, any ideas? Sudden cardiac arrest, all right? Defibrillation, of course, is where you shock them, all right? And the whole point for that, that's only done during 2 different rhythms, but the point of that is to basically get the bad ones out of line and make them stop so that the pacemaker can start back and regain control, all right? And ROSC, return of spontaneous circulation, all right? So that means, yay, they got a pulse back. Whether or not they actually make it's a whole nother ball game. But for at least a little while, you get a pulse back. ROSC, R-O-S-C. Oh, return of spontaneous circulation.
Isn't there another term for ROSC, Roscoe or something like that?
I don't know. There might be. It might just be saying Roscoe because it sounds better than ROSC. I don't know.
No, there was something, Miss Curry. It was written on the board in our class, and she
What?
explained it.
I didn't hear what she said. I don't know. I don't know off the top of my head. All right. Alkalotic states, we talked about that. Hemoglobin cannot deliver the oxygen as well as it needs to. And then as far as your O2 utilization in the cells, cyanide, other toxins, things like that, that actually prevent the cell from using the oxygen. So there's oxygen there. It's getting in. It's getting to the cells. But when it gets to the cells, they're like, no, I'm good. All right? You wait in line for an hour to go to the best new hot restaurant, and you finally get a table, and the server comes to you, and you're like, no, I'm good. I don't want to order. Doesn't make a lot of sense, right? Same thing kind of happening in your body. It doesn't make a lot of sense, but it does happen sometimes, okay? It will lead to cellular asphyxia. Asphyxia, y'all know, is like lack of oxygen, right? You're choking, you can't breathe, whatever. That can happen at the cellular level. And then, like we said earlier, when enough cells die, what dies? Tissues die. And when enough tissues die, organs die. When enough organs die,
You die.
we die. That's shock in like a sentence. All right. Now, moving on. That's all hypoxic cellular injury. All right. Cellular glucose use. All right. We've got to have glycolysis, the breakdown of glucose. All right, glyco meaning glucose and lysis meaning the breakdown or end of something. All right, they use the glucose to produce your ATP. That's the other part of the equation to produce the ATP there. All right, you can go through alternative mechanisms. For instance, if you have no glucose stores whatsoever, your body will try to go over to the liver, break down stored glycogen. All right, if you run out of that, you don't have stored glycogen, or if you don't have insulin to take this glucose into the cells, then your body will run on fats. It'll start burning stored fats. Problem with that is that burns also releases ketones. These ketones are acidotic and will make your body go acidotic. So it'll work for a little while, but eventually it's going to be effective and it's going to cause you to have some pH issues and imbalances. All right? So there are alternatives for fuel sources, but they're just not very good. They're not good long term. All right, kind of hit on this. The insulin has to be there to take the glucose across the cell membrane. What's the only thing that doesn't need insulin to get glucose?
Neurons.
More specific, well, less specifically, the brain, right? The nervous system. The brain doesn't have to have glucose to cross the blood-brain barrier. Everything else has to have insulin. This is why diabetics have to take shots with insulin when they eat, because they have the sugar available, it's just can't get into the cells. All right? Normal blood glucose levels, 80 to 120. Once again, this is kind of, relative. I've seen people functioning and seemingly totally normal and their blood glucose was like 40. I've seen people functioning normally, their blood glucose is 200, and they're like, yeah, it's a little low for me. All right, so, it varies a little bit, but that's considered your normal, your average, all right? And your insulin and your glucagon are constantly back and forth, raising the blood sugar, taking it out and using it, putting it away for later to keep it level in your body.
For kids, they usually lower that, like the blood glucose level.
They may be a little bit lower, but not by much usually.
I'm just wondering because like one time we were just transporting this little girl and her blood sugar level was literally 450.
That's high.
Like a 4-year-old.
That's really high. She's diabetic.
Yeah, that was the problem. Yeah.
She's diabetic AF.
Yeah.
All right.
Yeah.
The blood sugar, I remember I was working in Montgomery. It was hot. It was summertime. We'd been running our butts off. We had eaten breakfast. It was like 1 o'clock. I was hungry. I'd been sweating a lot because we'd been outside. Of course, the air conditioner wasn't working all that great. And we had been running back to back to back and had not stopped moving. And I was just like, I was getting hangry. And, no, it was just a busy day. It's just a busy day. Like a random Tuesday or something. And so we finally drop off one at Jackson and we get them on, we're going to eat. And so we boogie on to the nearest place. We end up at Crystal's because, we just did. And so, I was to the point my stomach hurt and I had a headache and I felt kind of shaky. And I was like, I'm just curious. I was in medical school. I was like, I'm curious. I want to see. I'm going to check my blood sugar. I was expecting it to be 60 or 70 or something because it normally hangs out right around 80 to 90. Unless I just ate a candy bar or something. And so I checked it, and it was low. It said low on it. I was like, John, look at this. And I was like, why am I conscious? He's like, because you're not diabetic, Jessica. I was like, explain that a little bit more to me. But, it all depends on how your body. My body could compensate long enough, and so even though it was very, very low, I still had enough fuel to keep going. I ate, and then I started feeling a little better. He was like, I'm driving back to the station. So, that's cool.
How long do you think it would have taken for you to swallow it?
I don't know. I don't really want to find out. But I felt more angry than anything else. I was just raging, I want to punch people in the face because I'm hungry. I was just but my stomach hurt. I just didn't feel good. But I don't know. I didn't feel I'm going to hit the ground or anything. And then I've met people. I was at the fire department one day working, and one of the police officers stopped by, and we were talking about blood sugar and stuff. I don't remember how we got on topic. And I was like, yeah, normal. He's like, well, my normal's 40. And I'm like, sure. He's like, no, check it. And I'm like, okay. And I check it. It was 37. And he's just bebopping through his day. And I'm like, I feel like you might need to get that checked. I don't know. I don't know for sure. But the point being, people have different things. So when you get something funky, look at the whole picture with them too.
So ask them if they know what their norm is.
Yeah, they know, maybe they know they run a little low. I've checked people's blood sugar and they're 300. I'm like, have you taken your insulin today? And they're like, oh no, it stays around 300. If I don't take it, it jumps up to about 5. That's called kidney transplant in a few years. You're gonna be. One thing you will note on your dialysis transports, the patients that you meet, they usually have the trifecta. Kidney failure, hypertension, and diabetes. The reason being, the diabetes and the high blood sugar lead to the kidney failure. Hypertension, chronically tightened up vessels, which decreases perfusion to the kidneys, problem number 1. Increased circulating glucose levels, chronically high, are very irritating to the kidneys. The kidneys are constantly working harder trying to pee out the extra. And so they're working that much harder with less blood supply. They wear out quicker. You end up with kidney failure. Very, very, very common. Anyways, you know what hypoglycemia is. Y'all know your signs and symptoms of hypoglycemia. Does everybody feel pretty good about that? All right. Your acidosis here. Moving on. Everybody, move back up. Everybody good with glucose use. That one's pretty straightforward for the most part. All right. Acid-base balance disturbances, electrolyte disturbances. All right. Your causes of your acidosis. These are things that are going to cause your pH to drop down. Hypoxia. When you have hypoxia, you revert back to that anaerobic metabolism and you have a buildup of pyruvic acid. So that leads to an acidosis, right? Right? DKA, diabetic ketoacidosis. With this one, you don't have enough blood sugar or insulin to take the sugar into the cells. So you've got high blood sugar, but you also will go to your backup fuel source, which is going to be your fats, so your stored fats, fatty acids. When those are broken down, you get ketones, they will increase your acidosis as well. All right? And then toxicity with acids. Aspirin, salicylate states. Bless you, I think. Antifreeze. So these things that can cause acidosis by ingestion. All right? The thing about the aspirin and overdoses with that kind of stuff, it doesn't usually kill you immediately. It kills you a week, a couple days, a month or so down the road with kidney failure, liver failure, and all that other fun stuff. DKA. All right, so with your diabetic ketoacidosis, you've got, normally you have to have your insulin and your glucose. So the insulin has to pair up with the glucose, take it in the cell. All right? And that does two things. It feeds the cells, and it gets rid of the extra glucose circulating in the bloodstream because we don't want too much. All right? If you have somebody who's going into DKA, for whatever reason, their glucose levels and insulin levels aren't matching up. So usually they've been sick, they haven't taken their insulin or something like that, and so the glucose stays in the cells. There's lots of glucose there, but there's no insulin to take it into the cells.
So it's not even high blood sugar?
So it's really high blood sugar, and then the cells are still sitting here going, hey, I'm hungry, I need some fuel, and when the glucose doesn't come, they turn to their backup source, so they start going with the fatty acids. And so they start building or burning off the fatty acids, which gets you by temporarily, but also releases ketones, which affect your pH as a byproduct. So that contributes to the acidosis part of it.
You said the glucose stays in the cell and the insulin can't.
The glucose stays in the bloodstream, and the insulin needs it to get in. It's kind of like if you're standing outside there and I have the door locked, you can't get in. But if I give you the key, which is the insulin, then you can get in. All right, so you can be out there, you're here in school, but you're not in the room where you need to be. All right, your metabolic acidosis. Now, we'll refer to a couple of different things here. We'll refer to things being either metabolic or respiratory in nature. And then we'll break it down into acidosis or alkalosis. We're just going to go with that. All right. Metabolic is, well, let me hit respiratory first. I'm going to go ahead and skip ahead a little bit. Respiratory, if it's a respiratory acidosis or alkalosis, the root cause is in the respiratory drive. Okay? So root cause is respiratory related. Metabolic is everything else. All right, so when you're looking at causes of things, whether it's a metabolic or respiratory acidosis, alkalosis, if the problem is rooted in the respiratory drive in some form or fashion, narcotic overdose, still respiratory because it slows down the nervous system, slows down the impulse to breathe. Slows down respirations and ventilations, you retain acids. Okay? So, respiratory related. DKA, diabetic ketoacidosis, not related to respiratory, so it's metabolic. Everything else. Okay? Now, arterial pH, less than 7.35 with a bicarbonate less than 24 millimoles. As far as bicarbonate, it's a naturally occurring substance and it's part of the buffer system that helps neutralize some of the acids in the body so they don't go haywire and wreck you. Okay? I don't know, I don't care that you know specifically what the normal is. Just know that if your bicarbonate level is lower, then that means it's getting used up, it's metabolic. If the bicarbonate level is normal, then it's going to be respiratory as well, if you're looking at like lab values. Okay? But all of this is based on what is that pH. Okay? So if it's bigger than 7.45, it's going to be alkalosis. And if it's less than 7.35, it's going to be acidosis. Okay? pH goes down, like we talked about with the hemoglobin dissociation curve. Hemoglobin doesn't bind as well to the oxygen, okay? So that forces you to stay in that anaerobic metabolism, producing less ATP, more byproducts, and it's just this perpetuating cycle that gets worse and worse and worse and worse and worse until you die. Okay? Now, some things that can cause your metabolic alkalosis. All right, antacids. You ever have heartburn? Take a Tums. Get the smoothie ones; those are better. Or if you're gonna get the fruit kind, the other ones are kind of chalky; they're not very good. Or the mint ones are the one. All right, but taking too many antacids can actually lower the pH in the stomach enough to where it lowers your overall body increases your pH enough to where it increases your overall body pH and puts you in a state of alkalosis. Now, I feel like that's a lot of, I don't know an exact number of how many times it would take to do that, but I mean, if you start chumping down on some bottles, you can kill yourself with it. I don't recommend it. All right? Vomiting, excessive vomiting. You know you've got a lot of acid in your stomach, essentially equivalent to hydrochloric acid, right? So if you, and here it all comes out, and you've now emptied your stomach of all of its stomach contents and acid, you could affect your body chemistry, raise your pH enough, make you alkalotic. Okay? And then excessive diuretics. Remember, the other part of this is the pH and electrolyte imbalances. One of the ways that our body keeps those electrolytes in check and in the proper balances is by pee. You know, if we're short on potassium, it'll kick potassium back in the loop of Henle in the kidneys. All right? If we're a little extra on the sugar, it'll pee out some extra. It'll let it go on through so you can get rid of the extra. So with your diuretics, that increases your urinary output, but it's non-selective unless you take one of the selective ones. But that is going to pull everything out. So that could actually long-term affect your electrolyte imbalances. All right? So alkalosis, pH is going up. Acidosis, pH is going down. All right? Causes of acidosis for your hypoventilation, all right? Respiratory acidosis, drug overdoses, pulmonary edema, chest trauma, neuromuscular disease, airway obstruction, COPD. All things that cause a respiratory issue, that cause you not to breathe enough, right? Because remember, not only is that respiration oxygen coming in, but it's also CO2 going out. And if you're not getting rid of that CO2, it's going to build up in your body as an acid. Okay? So just as important, or almost as important, as getting the oxygen in, new in, you got to get the bad out. Otherwise that pH gets all out of whack. All right, your diabetic ketoacidosis, facilitate overdoses, shock, metabolic acidosis, sepsis, severe diarrhea. All right, if you are, it's like a water slide out of there. You lose enough water that way, it concentrates what's left, can cause an acidosis. Renal failure. You're not pulling out enough extra so it can actually cause it to build up. Most all medications have a renal or a hepatic adjustment for it, meaning if they have renal failure, if they have liver failure, they actually will adjust the dose so it's less toxic for them because of their injured organs can kind of keep up and still do their job. All right. Remember, liver, number one, breakdown of your drugs. Kidneys, number one, excreter of the drugs. All right. When those things go bad, it's terrible on you. It's really bad. All right. Alkalosis, hyperventilation. You breathe too fast. Going back to this in and out thing. All right. If you breathe out too fast, you're putting out more CO2. What's going to happen to the acid levels in your body? Going to go up, so you're going to get more alkalotic. All right, so you're breathing off too much acid, so you're making yourself more alkalotic. All right, that's a really big of a thing. Makes your fingers numb, your hands can like go all lock up. Feet, they call them carpopedal spasms, hands and feet. You get numbness around the face, cyanosis around the lips. And eventually your body's gonna be like, go sleep. So you'll take back over breathing. But anyways, pulmonary embolus, hypoxia, pregnancy. How do you think how pregnancy would affect it? Position of the baby, but also in the later stages, usually like the last trimester. I mean, it's taking up all this space in here, and it's pushing everything else up. So it pushes on the diaphragm, which is in turn going to push on the bottom of the lungs, kind of. And so basically, it means you can't take a really good deep breath because everything's pushed up in there. So it kind of constricts your room, like how much area you have to actually inhale. All right, and then of course the high altitude, like we talked about. All right, as far as the metabolic side, overuse of antacids, potassium wasting diuretics, but loss of gastric juices. We already talked about all those as well. All right, so your signs and symptoms for your metabolic acidosis: headache, decreased blood pressure, hyperkalemia. You can't really check that unless you can do EKGs or do blood work, but there it is. All right, muscle twitching. This one's kind of fun. Extra potassium, extra magnesium, things like that, or lack thereof, will cause little muscle twitches. And it's literally like it's just twitching, or you might jump. You might actually see it, or you may just feel it. All right, warm, flushed skin, nausea, vomiting, diarrhea, changes in consciousness, Kussmaul respirations. That's that initial compensation. What's Kussmaul? How's that breathing going?
Does it sound like when they're about to die?
They might be about to die. Fast and deep, right? It's really, and it's their body's way of trying to breathe out some of more of that CO2 because we've got too much acid in our body. So if we can get rid of some of the CO2, that might help the balance of the acid in the body. All right. Some of your more common causes: DKA, severe diarrhea, renal failure, and shock. Can we do anything about DKA? We can give them fluids, try to dilute it out a little bit. Can we do anything about severe diarrhea? We can give them fluids. Can we do anything about renal failure? Don't give them fluids. Don't give them renal patient fluids if you don't have to. All right, and then shock depends on what the underlying cause of shock is. We can do something about it. All right, metabolic alkalosis, restlessness, lethargy, dysrhythmias. All right, compensatory hypoventilation. So basically, what's happening is their body recognizes that they're alkalotic, so it's going to slow that respiratory drive to try to retain some of that CO2 to try to bring that acid back into check. All right, confusion, nausea, vomiting, muscle cramps, things like that. And the tingling of the fingers and toes is one of the early signs, and if it keeps on, they will actually lock into place. Like they'll like spasm out, look like claws. All right, and that if they're conscious, that's going to freak them out. It's going to be fairly painful as well. All right, causes here: severe vomiting, excessive GI suctioning, diuretics, and excessive amounts of bicarbonate. Usually that's going to be like post-code or something. They go from extreme acidosis, from not pumping and everything, to extreme alkalosis if they give too much bicarbonate in it. And your respiratory acidosis, hypoventilation, or that leads to hypoxia, which then leads to not enough oxygenation. Rapid, shallow respirations, decreased blood pressure, dyspnea, headache, hyperkalemia, and dysrhythmias. A lot of the same overlaps. Y'all seeing a lot of the presentation? The presentation is going to be very similar in a lot of them. So it boils down to what's the root cause. All right? If it's decreased respiratory stimulus, drug overdose, COPD, something that's respiratory in nature, it's respiratory. Everything else is metabolic. Okay? Atelectasis. Can y'all see that word down there? Atelectasis? What's that one? Anybody know? That just means the alveoli have collapsed. That's where the alveoli have gone, bloop. And so they're not really present and accounted for, ready to do gas exchange anymore. All right, respiratory alkalosis. Seizures, can be seizures in severe cases. Deep rapid breathing, hyperventilation, tachycardia. Once again, a lot of very similar signs and symptoms to metabolic alkalosis, but you got to look at what is your base cause. Is it hyperventilation or is it mechanical ventilation? We can cause this in patients by breathing too fast for them. All right? And you'll see it when if you start paying attention. If you see somebody bagging them, watch how they bag them. Oftentimes you'll see that they bag them way too fast, almost double what they need to bag them. I don't know, it's like adrenaline pumping, something happens, and we start bagging them every 2 to 3 seconds, which is way more than we need to. Your electrolytes, you may have some abnormalities, they can cause different things that happen in your body. Pretty much all of them are bad. But we don't really have a good way pre-hospital to evaluate for those things. So we assume in certain cases that they're going to be there. For instance, if somebody's just gotten done running a marathon in Alabama in the summer, there's a very good chance, because when you sweat you lose electrolytes too, there's a very good chance they're going to be depleted of their electrolytes unless they've been replenishing them along the way. So you just got to kind of look at what the surroundings are. Can we replace some of those electrolytes?
Yes.
With what?
Lactated ringers.
Normal saline will give some of your sodium, but lactated ringers will give you a bunch of more. Those are actually the preferred fluids for your dehydration. But you may or may not have it. But if you have it, that's a good one to go to. All right. Big thing here is that and when it gets really bad, it can affect your cardiac output, your cardiac rhythm, cause disturbances. At the advanced level, you can't fix that. So what does that mean for you as an advanced provider?
Call ALS or run to the hospital.
Okay, if you're closer to the hospital, boogie on, and if you're further out, call for a paramedic intercept, because they may be able to do something about it. All right, they also have some of the electrolytes that you can give. All right, now, with shock, all shock eventually shares the final pathway of death. All right, that cellular injury, the tissue death, the cell death, all that whole thing there, they all end up there. It's just how we get to that point is different. Okay, we're all headed to the interstate. We may take 5 different routes to get there, but we all still end up on the interstate. Okay, that's what's happening kind of in your body. Now, 4 classifications of shock. What are they? Just saying.
Hypovolemic.
Hypovolemic.
Hypoglycemic.
Nope.
Neurogenic.
It's a broader category. That's one of the subcategories of one of them. Obstructive. Alright. So, hypovolemic. Alright. Distributive, which is going to cover your neurogenic. That's also going to be under under distributive. What's the third type of distributive? Anaphylactic. All right. Distributive, obstructive, one more. I am about to write it. Cardiogenic. Cardiogenic. Okay? Remember when we were talking, put up here yesterday, like pump, container, contents, right? Mm-hmm. Every form of shock is going to be a problem with one of those components in some form or fashion, okay? So we have the pump, the container, and the contents. All right? So hypovolemic, that's fluid issue. So is that going to be a problem with the pump, container, or contents?
Contents.
Contents, all right? Contents. Distributive. Container problems. Obstructive.
Container.
Could be potentially all of them, depending on what's causing the obstructive.
Yeah, I was going to say, my mind went to because it's something that's caused it.
All right, and then cardiogenic. Pump, right? Now, we're going to go through and talk about all of them, don't worry. Pathogenesis of shock, which just means the pathway shock's going to take, okay? So, you have inadequate tissue perfusion due to whatever, one of these problems, okay? Something's causing inadequate tissue perfusion. When you have inadequate tissue perfusion, it leads to inadequate glucose use. Remember the whole half of the equation, sugar and oxygen. All right, when you don't have proper glucose usage, a couple things are going to happen. Number one is you're going to have increased serum glucose levels, which just means your blood glucose is going to go up a little bit because it's not getting into the cells to do its thing. All right, that's going to lead to increased pyruvic acid production, which is going to start kicking that pH down and making you a little bit acidotic. All right, so that's happening over here kind of on the side. Additionally, you're going to have this whole chemical cascade that's going to happen in your body. You're going to have release of catecholamines, cortisol, and growth hormone. Growth hormone to make up for your short-term cellular adaptations. Cortisol, stress hormone, is going to kind of get your body prepped and ready. Catecholamines, what are those? Catecholamines.
What you're gonna say?
As you know. Alright, so catecholamines is just a term for basically chemicals that are released from your sympathetic nervous system. Okay, and they all do different things. I.e., epinephrine and norepinephrine. You ever heard of those? Mm-hmm. Okay, so epinephrine, which was released from your adrenals, okay? Epinephrine is going to go and it's going to cause vasoconstriction because part of this whole perfusion thing, you got to have adequate oxygen and adequate perfusion to get it there. So it's going to cause a little bit of vasoconstriction. It's going to reroute the blood. It's going to draw it away from the skin because the skin at this point, you're good. It can hang out for a while without full perfusion. It's going to reroute it to the heart, the lungs, and the brain to make sure that we get enough to the vital organs to keep making it through whatever's causing this problem. Okay? Then, that epinephrine's also going to cause an increased heart rate and increased respiratory rate because we've got impaired tissue perfusion. So your body's going to try to start fixing the problem. All right? It's going to cause some glucose to be released from the liver, most likely. It may cause some more insulin reserves to be released if you've got them. But then it's going to try to circulate and get more oxygen to fix whichever part of the equation it can. So when it increases the heart rate, what's it doing? It's moving oxygen, pumping blood faster through the body to try to improve tissue perfusion. When you breathe faster, you're trying to get more oxygen in to improve tissue perfusion. Does that make sense? All right, so all of these things, do y'all recognize those as, y'all know what those are? Signs, symbols of shock, right? Mm-hmm. What do we look for? Pale, cool, clammy skin, diaphoresis, right? All right. Tachycardia. Why do we have all of those things? Those are just the outward signs of the catecholamines going to work in the body. So we recognize those as shock because if those are happening, shock is happening. I mean, I don't know why, but it's happening. All right. Once those things happen, a whole bunch of different things are going to happen. It's going to increase the breakdown of glycogen, which is what I was talking about with the liver. So it's going to try to release some stored glucose to be available, but then your stores obviously are depleted, so they have to be put back together at some point. Increased glucose production here, which is going to lead to breakdown of your proteins. The albumin and amino acids and stuff, I'm not so much concerned that you know about those, but know that when those things are released, they're going to decrease your osmotic pressure. Okay, remember the osmotic pressure was what kept your lipid ends together and kept the cells kind of in their ready state. It would give them structure and kept them proper where things move back and forth the way they're supposed to. Okay? When you lose that osmotic pressure, fluid starts going willy-nilly, and it may move into places it's not supposed to, like out of your vasculature into your cells or into your interstitial tissue. All right? That sounds a little bit familiar from yesterday? Okay. Then, once that happens, it starts bringing out fluids, and then you lose your intravascular fluid. Well, what happens when you've got a set container with a set amount of fluid, and now you're losing some of it? That pressure is going down. So then decreased hypotension, decreased pressure, leads to even worsening tissue perfusion. So it's just this really vicious cycle that's going to go on and on and on until something stops it or we die. One of the two. Does that make sense? Okay. So that's shock. That's how shock does its thing in the body. How we get to this point is the different types of shock. And more specifically, what we're going to do to try to intervene and stop it from continuing on in this cycle. Okay? So your hypovolemic shock, this is blood volume, loss of blood volume. Now, it can be a relative or actual, meaning you may be bleeding out and you're losing blood, or you could have had really severe burn and now you're losing volume because that fluid is shifting from the cells or from the vasculature into that cell area where the tissue where it was burned. So it's not left your body, but it's not in the right place. Does that make sense? Okay? So for whatever reason, however we got there, whether it's blood loss, volume loss, whatever, vomiting, excessive vomiting, diarrhea, can that cause, can you lose enough volume that way cause hypovolemia?
Yeah.
Absolutely.
Dehydration.
All right. So whichever way we get there, we've lost enough volume. Perfusion's going to go down because we don't have enough in the vasculature, in the container, to keep circulating adequate amounts of glucose and oxygen. All right. And when that happens, that whole cascade kicks in and starts happening to try to fix the problem. Okay. Now, if this is short term, your body can make up for it. All of these chemicals can keep you going long enough to for your body to fix the problem. But sometimes if it's a really severe problem, like you're missing a leg, you can't make up for that blood loss fast enough to let the body heal itself. Does that make sense? All right. So your phases here, okay, and they're very evident in your hypoglycemic or your hypovolemic, but they kind of go across the board. Compensated, decompensated, and irreversible, right? Compensated means what?
You're in.
Your body is still enough to keep going, like it's making up for it. All right, it's BSing its way through, if you will. All right, it's doing enough to keep it going. Decompensated. We're still alive. We're still alive, but we're starting to lose that battle. We're getting overwhelmed, and we're starting to lose that battle. All right, your signs and symptoms are going to be, along with that. And then irreversible.
FTD.
We're too far along. It's just a matter of time. We've tipped the scales, and now we're going. It's a matter of time, but we will die. They will die, and there's nothing you can do about it. All right. Now, your classic signs and symptoms here. Classic presentation of shock: pale, cool, clammy skin. So, what makes you pale and clammy? That hypoxia, but also that shunting that happens with the epinephrine and norepinephrine, pulling blood away from the outer, pulling it into the core. All right, so that gives you that paleness and that coolness, that clamminess. All right, tachycardia, that's that epinephrine increasing the heart rate to try to increase circulation. Okay, decreased blood pressure is a late sign. So if you see hypotension, they are in decompensated or irreversible shock. All right, that's not good. That's no bueno. All right, what's the hallmark between decomp and irreversible?
The organ system shut down?
Bradycardia, which is you see as failure of the heart, essentially. All right, so when you get bradycardia along with these other signs, it's what they call an omnis sign, which just means very bad. All right. So your pathogenesis of hypovolemic shock, you've got decreased intravascular fluid volume for whatever reason. All right. When you've got decreased fluid volume, that means your preload coming back to the heart is decreased, right? So when your preload coming back to the heart's decreased, your cardiac output is decreased. With me? Cardiac output decreased, your body's going to do a couple of things because it says, warning, that's not good, and it's going to try to start fixing this a little bit. So it's going to do several things. It's going to have a splenic discharge, which sounds nasty, but all it means is that little reservoir over here in the spleen is going to kick it out. Sometimes that extra 350, 500 mLs can be the difference between yay or see you later.
If we're transporting a patient, they are in irreversible shock. They have the decreased blood pressure, bradycardia, and then they code. Can we call med control and request permission to not?
No. If it's a witness code, you will always work it, no matter the cause.
What about the traumatic arrest?
That one's a little bit on the gray line because on one hand they say if it's a witness code, they're not supposed to give you permission to call it. But if they've got signs incompatible with life, you can.
Yeah,
like if they don't have a head, or if they're cut in half, or missing a whole leg, or they got half their head blown off or something. In that case, I would say, yeah, probably so.
like you folks went out like a bad car wreck.
Well, we went
They were unstable from the get-go.
Oh, you might have to. I've worked in areas where it's you and your partner, and you ain't got nobody else, so you've got to start working on education and stuff. I mean, there are limits to what you can do.
Well, we're not allowed to, we're not even allowed where I work at to even pull our fire extinguisher out to go.
Do y'all always respond with another agency that does extrication?
It
Because
depends.
if not, they are setting you up for failure.
Well, it depends. Like, we just got this new little protocol with, like, when fire comes to scene, or what they come to, what they will come to the scene for, like whenever we get called out to, like most of the time.
I hate politics.
Yeah.
I hate politics and city politics
It's
and all
like
that
they're
crap.
only allowed to come to certain calls, and like we can't even do like lift assist no more with like 2 ambulances or something like fire.
That's somebody waving it around saying who's bigger. If you've got multiple patients, that gives you more leeway because you can only handle one effect at a time. So even if they're not all the way dead yet, you can focus on you're basically doing triage. If you've only got one patient, if I get on scene and they're alive and then they code, if they've got those incompatible signs of life, like half their head's missing or it's crushed in, or they're missing limbs and type things, then I'm probably going to call doc. Because no matter how much you pump on that chest, if there's, no blood in there, you're just moving nothing. But, if there's any chance, I'll try. But in certain circumstances, you can call it. But on a medical code, if you witness arrest, you're going to work it.
I was asking,
No, I was talking about traumatic.
He asked about medical, about witness arrest or whatever. If they're in shock or something, then.
Yeah, I was asking like traumatic shock.
Traumatic is really kind of a different ball game, and y'all are kind of at a disadvantage as AEMTs because paramedic you get a little more leeway with what you can call and not call because you've got your EKGs that you can look definitively and see no cardiac activity. Not y'all don't have that, so you're gonna have to have like they're really dead before they'll let you call a code. But. And some of it goes into SOPs, state guidelines, and what they say. Different states may have slightly different criteria for what's eligible and not eligible. Well, that depends a lot on where you are and how you work. All right, so splenic discharge, antidiuretic hormone. What's that gonna do? Break it down. Antidiuretic means what?
It's going to keep water in.
It's gonna keep water in, right? So that hormone's released. That's gonna work on the kidney, and it's gonna tell the kidneys, hey. We're having a little bit of a low spot over here. We need you to not pee out extra. Keep it in. Bring it back in to circulate. All right, so we're discharging the spleen, got a little extra there. We're keeping fluid in, we've got a little extra there. Interstitial fluid shift is going to pull some of the fluid from the surrounding cells and tissue to try to put it into the vascular system, so a little bit from here. Then aldosterone, also going to do some work on your kidneys and affect how much you put back in and how much you pee out. It's kind of reinforcing the other. All right. Increased catecholamine release. We were talking about that, and what does that do? Epinephrine, norepinephrine is going to cause that vasoconstriction, pull it away from pull it to the core, shunting. All right. Also going to cause increased heart rate, increased respiratory drop. So we've got circulate what we got a little bit better and faster, and let's pull little pieces all in to try to dump in a little bit extra, because a little bit here and a little bit there adds up to a lot, right? All right. So all of those are going to hopefully lead to increased intravascular volume. All right. Increased heart rate, increased stroke volume, pumping harder and faster. Together should increase cardiac output, right? If we continue to lose fluid, though, we go back down to decreased cardiac output, decreased tissue perfusion, and we've already used our reservoirs. So that's when you start going towards more of your decompensating, because we've already used up all of our backup plans. And now we're still losing volume. That's why it's important to kind of interject in here and see if you can't stop the problem. If it's hypovolemic, can you give them fluids to help fix this problem?
Yes.
Yes. If it's hemorrhagic, can you give them fluids to help fix this problem?
Yeah.
A little bit. You don't want to give too much because you want to let the body's natural clotting factor start clotting. You don't want to wash away any clots. But you can also maybe help stop the bleeding. You know, if you can get that bleeding stopped, you can retain what's left in the intravascular volume and hopefully give it enough time to produce enough extra to keep you going. All right? Does that make sense? Okay. Now, at the vascular level, okay, you've got 3 phases. They kind of line up almost with your shock, your compensated decomp and irreversible. Ischemic phase. Now, with it, I'll leave that up there. With this, remember the vessels you got coming in, your arteries, your veins going away, you got all your capillaries in between, right? All right, so you've got little sphincters. We know what sphincters are now. We've got little sphincters at the entrance and exits. Okay? So that shunting that happens all around the body, your precapillary and postcapillary sphincters close. And that's how we shunt. So it says, skin, you're good for a little while, we're going to reroute you. So you close off here, and what happens is it bypasses it. And it keeps on rolling, and it's bypassed all the way through till it gets back to the core. Okay? So we're improving to the organs. Now, that's a good thing. That allows us to increase perfusion to the heart, the lungs, and the brain in times of need. Now, if the problem gets fixed, these sphincters open, all is well in the world, and we keep on rolling. But if it's not, okay, if this problem is not resolved rather quickly, we go into our stagnant phase. And here's what happens. Eventually, this tissue says, I can't wait anymore, I've got to have blood. All right? So your sphincter is going to open up and new blood is going to come up in here in the capillary beds. Okay? And then this one over here, it's a stronger, it holds out longer, it's still closed. So the blood comes in, gas exchange is happening, there's waste byproducts of here from anaerobic metabolism, but it stays there still because that postcapillary sphincter is closed. What happens to blood when it gets stagnant?
It coagulates.
It starts getting coagulation. It's almost like a stagnant little pool of water. You just kind of smell it, just not very good. All right? That's kind of happening in your blood here. So you get little microemboli. You get that toxin buildup from the anaerobic metabolism. Now, if this is a finger's worth of tissue, you can absolutely make up for that, right? But when this is happening all over the body, now we're getting a fairly substantial buildup of these toxins. Does that make sense? All right? Now, if the problem still doesn't get resolved, eventually this sphincter gives up the ghost and it can no longer do its job and stay closed to keep it all in. It's like a dam rupturing. And then all of these little microemboli and toxins and things that have been building up in this capillary bed get off into the vasculature and start sweeping throughout the whole body. And then they wreak havoc. That is when you usually start getting towards your irreversible phase. When that happens widespread throughout the body. All right? Now, hemorrhagic shock is just a specific subset of your hypovolemic shock, specifically due to blood loss. Problem is, blood loss may not be glaringly obvious if it's internal. So, if you have shock, signs of shock, especially if there's a trauma or something else, and you don't have any obvious causes of shock, consider internal bleeding to be maybe your source. That could be your problem, okay? Consider that one. Your leg can hold well over a liter before it shows any external signs of problem. Your abdomen can hold, depending on the size of the person, 2 to 4 liters of blood before it starts distending. That's a lot. That's almost all of your blood in your body. All right, so you can lose a fair amount of blood before you see any outside signs that something's going on. All right, they divided up the amounts into hemorrhages for classes. Class 1 up to 15%, 750 mLs. If you give blood, they usually give half a liter, 500 milliliters. All right, well tolerated, may have a little bit of mild tachycardia, but not bad. Class 2 hemorrhage, 750 to 1500 mLs. That could be one femur. All right, moderate tachycardia, pale skin, delayed capillary refill. So a little shocky, but still compensated. All right, class 3 hemorrhage, 30 to 40%, 1500 to 2000. Tachycardia and compensation starts to fail and leads to hypotension. So now class 3 is leading towards decomposition and compensation. Class 4 hemorrhage, 2000 to 2500, like half of it, all right? Profound hypotension, that just means really, really bad hypotension. We're talking like 60 over, 50 over kind of stuff, not just like 80 or 40. All right, end organ failure. Anuria is lacking of urine, right? We're usually not going to be with them long enough to see that they're not peeing. I mean, because, most people can go a little while without peeing, so we're not really going to see that part of it, but where we will see it is going to be brain function, like consciousness and type things, and bradycardia, because heart function. That's going to be your most reliable indicator there of that. That's pretty important stuff. I'm just saying. Blood volumes and classes of hemorrhage. I probably know some of it. At least one of them. I'm just saying. All right, hypovolemic shock, hemorrhage, plasma loss through burns, decreased bodily fluids, GI, diabetes insipidus, excessive peeing out of the extra sugar, and diuresis, all right? All these things can cause your hypovolemic shock. So what's our treatment?
For that guy in the picture?
For that guy in the picture, what will be our treatment? Say a prayer, say a little prayer for you.
Can we call that one?
That one, maybe.
So he might be allowed because the
it's a little low. It's still a little low. His eyes aren't quite closed. So if it's blood loss, you will want to give fluids to an extent, and this is what we're going to call permissive hypotension. Okay, permissive hypotension means we're going to let them be a little hypotensive, but not so bad that they die. Typically, a good rule of thumb is if they are hemorrhaging, 80 systolic. All right, and if it's a non-hemorrhage, 90 systolic. The point here, or the goal here, is to get enough fluids to perfuse to the organs, the brain, the heart, the lungs, but not so much fluid that you're literally washing away clots as they're forming, because then that's just going to make you bleed even more, right? 20 years ago, you were taught pump them full of fluids as much as you can get in them, as fast as you can get in them, and you might put in 2,000 liters in a 15-minute haul if you've got 2 14s. All right? And by the time they got to the hospital, they were bleeding pink because there were more saline in their vessels than there was oxygen-carrying red blood cells. All right? We don't want to do that. That's very counterproductive. You know, that whole do no harm thing. So we're not trying to get their blood pressure normal. We're just trying to get it to enough to perfuse the vital organs. All right? Now, cardiogenic shock. This is a pump problem we decided. With this, heart does not pump sufficiently to maintain cardiac output. The blood's there. The transport system's fine, but the pump itself is failing. All right? Usually, this is going to be due to either cardiac dysrhythmia or an MI, an acute heart attack, one of the two. All right? Now, usually going to have chest pain. They may have pulmonary edema because what happens if the blood's not pumping forward, it's going to start backing up. So when it backs up from the left side, it's going to back up to the lungs, which will seep across the capillary beds, fill up the alveoli. All right? Now, our treatment for hypovolemic shock was give them fluids. What's going to happen if you give somebody in cardiogenic shock fluids?
You're going to kill them.
It's probably going to kill them a little faster. All right? Because you're putting more fluids into an already overloaded system with a pump that can't handle it. That pump's going to go out even faster. All right? So treatment for cardiogenic shock, managing the airway, maybe some prayers, and rapid transport. Cardiogenic shock has a very high mortality rate because there's very little that you can do for it. If they're hypotensive, it puts you in a bigger quandary because if they don't have enough fluid to perfuse, they're not going to get better, but if you put too much in, then it's going to make it worse. So sometimes you're kind of dancing with a very tight line as to what you're doing for them. All right? So your pathogenesis of your cardiogenic shock. You've got myocardial dysfunction. Heart's not working right. If it is a diastolic function, all right, this is going to be residual pressure. Increases your left ventricular side, all right? Basically what this means is that your left side can't pump the fluid past the pressure in the system, so it backs up. And when it backs up, it goes into the lungs. When the lungs fill up with fluid, what do we not do so well? Breathe, which leads us to more shock, hypoxic cellular injury, pH disturbance. So they all just kind of cascade onto each other, all right? So that's diastolic, that's residual. That's like long-term chronic heart failure type patient. All right, now, systolic valve function. This is an acute, usually, decreased cardiac output. All right, decreased cardiac output is going to activate all these things that we talked about with hypovolemia that are going to increase blood volume. What's increased blood volume? Because your body recognizes decreased output, hey, we need more. But what's going to happen when we've got a failing pump and we try to increase blood volume even more to make it up for it? It's going to go downhill even faster. All right, so we're going to increase the blood volume. Catecholamine release is going to increase systemic vascular resistance. Basically, that's blood pressure. All right, that's how tight the vessels are, how easy it is to pump against it. So catecholamine release is going to make it harder. It's going to tighten up those vessels. So now the heart, that's already failing, has to pump even harder to get the fluid out into the body. Not very good, right? Doesn't make a lot of sense. And this one's the one where it's kind of, is why it has a very high mortality rate. All right? So increased preload because of increased volume, increased heart rate, increased stroke volume means more work on the heart. More work on the heart. When you use the muscle more, you need more oxygen, right? When you need more oxygen and it's already failing, what's going to happen? Decreased perfusion, decreased function. All right? Leads to decreased cardiac output, which leads to a further fall in blood pressure, which leads to a further decrease in tissue perfusion, which leads to cellular metabolism impairment. See kind of how it goes? It sucks. There's not a whole lot you can do about it because what the body tries to do to fix it kills it a little faster. It's kind of a lose-lose situation on that one. All right, so our pre-hospital treatment, supportive care basically. All right, supporting that airway, the breathing and circulation. If they code, you will do compressions. If they're having difficulty breathing, if they've got fluid buildup in the lungs, you may do a CPAP. All right, you may breathe for them because that's also positive pressure. Okay, there are treatments, medication that they can give to help. We can't, at the advanced level, can't give any of those. All right, so this is going to require transport to an appropriate facility. Even at the paramedic level, ain't really got a whole lot we can do to help this. All right, so very high mortality rate. All right, and there's just little signs and symptoms thing you can look at. All right, distributive. This is your container problem. 3 main types of distributive shock. How we get there is a little differently. How they present is a little different, but they all end up at the same place. Okay? And that same place is uncontrolled vasodilation. With your neurogenic, you've got loss of sympathetic tone. When your nervous system's working, it keeps tone. And basically what that means is it keeps everything kind of in a ready state. All right? When the nervous system, and that includes the vessels, so when the nervous system fails for whatever reason, brain injury, spinal cord injury, it loses control over that muscle, and when you lose control, they all relax. They go, and it all relaxes. So now you've got the same amount of volume, same pump, but now your container's gone from this to that. And so you don't have the same pressure. That make sense? Okay? With your septic, similar, but this is due to infections of some sort. And what these infections do is kick off this cascade of all these chemical reactions that are going to cause histamines and ultimately cause the vasodilation. I don't care that if you know exactly what all of those cascades are because it makes your brain hurt. But you do need to know that it's your body's response to the pathogen that causes it. And the chemicals that happen, they cause the vessels to become leaky and they cause the vessels to dilate. Okay? With your anaphylaxis, you get an immune response again, but this is due to an overreaction. You have mast cells and basophils, and they will actually cause histamine release and prostaglandins, and those will cause capillary permeability and dilation. Increased capillary permeability means that basically it's easier to pass things through the cell. If you get stung by a bee on your finger and that little area swells up a little bit, that's normal and that's what it's supposed to do because you want your white blood cells in your immune system to be able to get out of the bloodstream, go to the problem and fix it, right? So localized, totally okay. But when you have increased capillary permeability all over, all at once, now you've got all of your volume trying to shift out. So then you don't have enough left over in the vascular system to maintain that pressure. All right, so that's how you get to the anaphylaxis portion of it. All right, now, with your neurogenic, it's a little different as far as presentation. You know, normal signs of shock, you get pale, cool, clammy, all that fun stuff. With this one, you're going to have skin that is warm, dry, and pink usually. The reason being, those catecholamines, norepinephrine and epinephrine, are released and mediated, controlled by the nervous system. Well, if your nervous system pathways are destroyed or damaged where nothing gets by, The chemical mediators that cause those can't get by either, so your skin stays normal. All right? Heart rate stays normal. Once again, catecholamine, pathways are destroyed or damaged, doesn't get to the heart, doesn't kick it into overdrive. All right? And depending on where exactly it is, you may, if it's really high up in the cervical, you might have impaired ventilation, which is kind of like a kick in the ass after all this is happening too. All right? Neurogenic shock, spinal cord injury, autonomic nervous system imbalance, leads to massive vasodilation, which leads to decreased systemic vascular resistance, which means basically all your vessels are dilated. Massive vasodilation leads to decreased preload. Excuse me, that's my turn. Decreased preload, which means leads to decreased cardiac output, which leads to decreased tissue perfusion, which leads to impaired cellular metabolism, and eventually death. Are y'all seeing how it's going? How are we doing? Okay, we're good on time. All right, there's another pretty little picture if you'd like to go look at it there in Canvas. Pre-hospital treatment. Manage that spinal cord injury accordingly. Okay? Airway management, supporting ventilations as needed, oxygen as needed, keep them warm as needed, and fluids to try to, basically at this point, you're trying to fill up the container some so that it's enough pressure to keep everything circulating. Because it's just your container's gotten way bigger, so it's going to take more stuff to fill it up. So you're trying to put more stuff in there. That stuff's not going to carry oxygen, but it may support perfusion enough to transport what's there. All right? Anaphylaxis. It's a severe overreaction. It's an extreme allergic reaction, okay? So, allergic reaction, you walk in your house, you see a spider, you throw some shoes at it and maybe a baseball bat. A little overreaction, but still acceptable, right? Anaphylaxis, you walk in, you see a spider, you burn the house down. Okay? It's a fairly extreme overreaction to it. Right? Still reasonable? Look, I'm with you. My husband decided it would be really funny, like our first Christmas together, to give me a new ring because I'd lost my old one working on putting a radio in a car. And then, so he bought me a new one, but he put it in its box in a cage with a little tarantula. Because a real one. Because he knows I'm scared of spiders.
So why did he bring you this home?
Because he thought it was funny.
What did you do with it?
I didn't do anything. He got the ring out. And then I went to Walmart later on and bought a lock for that box. I mean, I drop a cricket in there every now and then, but I told him right up, I was like, look.
You still have that stuff?
No, it died.
Suspiciously or naturally?
I don't know. I came home one day and it was dead.
Did you set up a bomb off in this container and then leave?
No.
Or feed it for a few days?
No. I don't. Honestly, I think because I ran out of crickets and so I sent Clay out into the yard to find a cricket, and I think that I guess maybe the cricket had poison or something from just, I don't know, maybe like spray for mosquitoes or something. I don't know. That's what I think happened to him, but he died.
Did you at least name it?
No. I don't want to impart any partiality into it. I didn't want to think I liked it or anything. But no, I locked the cage, and I told James, I was like, if I ever come home and it's not in its cage, I'm out until you bring me a spider body. Like, it or me. We can't both exist outside of this cage. It never got out, though. Look. Oh, so scary. So scary. Anyways, so some of your more common causes of your anaphylaxis. Antibiotics. Hymenoptera, which is just a stinging insect. Bees, wasps, little mechanisms of doom and death, I call them. Yellow jackets are mean, y'all. Bees, they're okay. They're just little fuzzy duzzies. They want to make some honey. Yellow jackets will seek you out and try to destroy you just because you looked at them wrong. All right? And peanuts. Peanuts, one of the biggest food allergies there. Antibiotics, that one's a kicker because you may be fine. You may have taken the antibiotics before, and then one day your body's like, nah, dude, I don't think so. I'm going to get it. All right? I don't take, like, if I get sick and I get an antibiotic, especially if it's a new antibiotic, but I don't take it at night. Because the thing with the ingested things is it takes repeated exposures to set off a true anaphylactic reaction. So let's say you take one at like 2 o'clock in the afternoon, and then you take the next pill at 8 o'clock in that evening. Well, now you've had that second exposure to it. Your anaphylaxis may not start until after you've gone to bed. You might die. I'm just saying. Be careful with it.
Nice.
Start on the next day. Either start them early in the day where you have the whole day to evaluate, or start them the next morning. That's all I'm saying. Now, if the doctor's like, you're going to die if you don't take it, I mean, I guess I would take it. But if I have any leeway in it whatsoever, I don't know. This class will give you just enough to make you a little bit paranoid. Like when you get a headache, you're like, brain tumor? Dehydrated? Which one? I don't know.
I think that you try to get
Heavy ponytail? Do what?
I don't think about it till you say zero.
I know, but then you think, but now you think about
Yeah,
it.
because you said it.
Well, somebody said it to me and made me think about it. I'm just sharing the love.
See, I was telling you the other day, same thing.
You don't want my love? Is that what you're saying? Anaphylaxis, all right? So exposure to the antigen at some point in your life, whether it be when you were 2 or whether it be 20 minutes ago, all right? Then you have a repeat exposure to an antigen. Now, it's a little bit of a misnomer because you can have a severe reaction the first time you ever get exposed to something, but that's fairly rare. All right, that doesn't happen very, very often. Usually you've had some, at least a minor exposure to it at some point in the past. All right? But, so you have a repeat exposure. It's that same thing. So what your body has done, the first time it saw it, it's like, I don't like you, I'm going to kill you. I'm going to remember you next time I see you. So then if it ever sees it again, it's going to release the entire army to go after it. Okay?
Like chicken pox.
Like chicken pox. Oh, terrible. They don't have it. They all got shots. Youngins. You had it? Maybe not.
I didn't get it.
Who all had the chicken pox shot? Who all had chicken pox? I still got scars from that stuff. Like my mama, when my cousin got chicken pox, she took me to their house and put me in bed and made me spend the night with her. So I would go ahead and get it. I'm like, we played Barbies and then I got chicken pox.
Did you wear mittens around your hand?
Yeah, she made me do that because I was sitting there like, I know I'm not supposed to eat, I can't help it. Like bleeding. The bitches. I was pink from calamine for a while. Alright, so anyways, immune system kicks in. You've got a large release of histamines, prostaglandins, and kininins. I'm more concerned that you know the histamines, okay? Because that one is something you can do something about. Antihistamines, diphenhydramine, Benadryl. See? Alright, anyways. So those things cause bronchoconstriction, laryngospasms, and GI upset. Can we do anything about a bronchospasm? Yep. What do we do? Albuterol. Can we do anything about GI upset, vomiting?
Yes.
Zofran, alright. Those things also cause peripheral vasodilation, which decreases your systemic vascular resistance, which decreases your blood pressure, decreases your cardiac output, decreases your tissue perfusion, and decreases your cellular perfusion. Alright? So, our treatment, and the increased capillary permeability, which leads to your swelling. Alright? Our treatment for this, it depends on how severe it is. Alright? So, basically your cutoff here, if they are having an allergic reaction, you may have hives, welts, wheals, things like that, itching, urticaria, but you won't have respiratory or cardiovascular involvement or shock. Okay? If you have respiratory, cardiovascular, or shock, it's anaphylaxis. And you're going to be a little more aggressive with it. All right, so what's our treatment for this? Epinephrine IM, 0.3 to 0.5 milligrams. For peds, 0.01 milligrams. We'll talk about that again when we get to the immune system. Just throwing that out there for you. All right, Benadryl. What's our dose for Benadryl? Anybody know? Top of your head?
25 milligrams.
25 to 50 milligrams IV or IM. Maybe albuterol if they have respiratory involvement, and maybe assisted ventilations as needed if they have respiratory involvement. Okay? That epi is going to cause vasoconstriction. It's going to cause those vessels to shrink back up. The Benadryl is going to stop the leaky capillaries. And the albuterol is going to open up the bronchioles. So you're kind of attacking each problem as it goes. All right? Some causes, just a pretty little picture there for you. All right. We talked about that, we talked about that, we talked about that. Septic shock, that systemic inflammatory response. High fever, which old people may or may not have. When I say old, it'll be like really old, like geriatric age. Tachycardia, respiratory stress, decreased mental status, and hypotension. I'm just going to go ahead and throw this out there for you. If you go somewhere and that person is elderly and they have altered mental status and they have a fever, there's a very good chance they've got a UTI that's gone septic. Very good chance of it. All right? So there's your pathogenesis of your septic shock. So lots of cell things happen. Your white blood cells, your platelets, your immune response happens, releases lots of chemical mediators, and it causes tissue damage. And then that tissue damage causes all those things to happen, and those are the things that kill you. All right? I'm not as concerned that you know what every one of those are. I don't care if you know all those or not. I care that you know that this causes an immune response, that causes tissue damage, that causes you to go into shock. Okay? That's all I ask of you. That's as far as I ask of you to take it. All right? That's how it actually happens, which is why I don't ask you to know all of that.
Next slide, please.
It's gonna make you mad looking at it. All right. If you want to look a little further in depth, it is on canvas there for you. All right. Now, moving on. Obstructive shock. This is something that's physically blocking either the flow of blood or the onloading of blood. Okay. It's blocking something else from doing its job. So, your main cause is pulmonary embolism, blocking part of the blood flow to the lung section. It's no good now for perfusion, right? All right. So we're blocking the onloading. Tension in the thorax. We've collapsed the lung. That whole lung's out. It can't do its job. We're not getting adequate oxygenation. And then pericardial tamponade. Now this one gives people fits sometimes. Pericardial tamponade, people try to make it cardiogenic. But if you think about it, it's kind of like somebody's giving it a big old bear hug. All right, the heart itself is still pumping just fine, but the skin and sac around it is filling up with fluid and squeezing on it, and so now it can't pump effectively. So it's not the pump itself, it's something blocking the pump. So therefore it's an obstructive shock. Okay? So with shock, once again, for the 5th time today, maybe 50th. However you get there, your signs and symptoms are going to be pretty similar, but your initial or your end pathway is going to be the same. Decreased cardiac output, decreased tissue perfusion, cellular death. Okay? You're going to say that in your sleep tonight. Maybe tomorrow night, I don't know. But you've got to know those pathways. You've got to know that pathway there, okay? So signs and symptoms, your early signs, oriented but restless, maybe apprehensive, increased anxiety, increased pulse, not really decreased blood pressure yet though. All right, intermediate signs, decreased sensory perception, slowed speech, cool moist skin, rapid shallow respirations, paleness, may start getting some cyanosis, okay? And a late sign, anuria, cracked blood pressure, significant hypoxia, cyanosis, and bradycardia. All right? Your role, recognize it, do what you can to try to fix it. All right? As far as your hot and cold, your environmental, we've got to have that core temperature. If, like we said earlier, way earlier, if we're too cold, our body's going to try to generate heat. If we're too hot, we're going to try to cool off. All right? We've got a bunch of different ways that we try to do this. When you have a state of shock in your body, you cannot adjust the temperatures as well, and so when your temperature gets out of whack, it makes the problem that much worse. Does that kind of make sense a little bit? I got a spot right in the middle of that little itch. Okay? You know about shivering, you know about that. The main thing with this is just temperature regulation. When you're in shock, you lose some of that temperature regulation, which just makes everything else worse. All right? So, summary. All these things will happen. Shock is bad. All right. Inadequate cellular energy production, inadequate cellular function, we die. Figure out what's causing it. Do what you can to try to fix it. Provide supportive care. Understand how it happens and what to do about it. Any questions? Would you know if you had any questions yet? If you think of any questions over the weekend, feel free to send me a message. They make me laugh. All right, y'all have a lovely weekend. Be safe. Tuesday, we'll do some more peer evaluations in the lab. We'll be doing the same 3 skills, plus I'll introduce your IM real quick. If you do want to try to go ahead and get your checkoffs, you're more than welcome to, but I do want you to get at least 1 peer checkoff before you do it. But if you can get all 3 of them, awesome.